Okay guys, I'm audible. Can we start the session? एक बार इसमें वाईफाई और कनेक्ट कर दो. आ जाएगा उसमें से आ जाएगा. Okay guys, so let us discuss only the important topics which are expected to come in this exam. So without wasting much of your time, let's start with the first topic. In last attempt there were 3 questions in exam. So this is your ABG, arterial blood gas. So first try to understand. They ask you numerical based question, means आपसे हमेशा question कैसे आएगा? Numerical based. Most common artery that we use, this will be your radial artery. So whenever we are doing an ABG sample, remember what we do, we extend the arm and the needle is inserted at 45 degree into your radial artery, and then we take the sample. Before sample, what we perform a test. The test is called modified Allen test. So procedure is simple. Extend the wrist, we have to locate the radial artery, perform this test, then puncture the site, take the sample, discard the needle and send this via cold chain. So sometime what they ask you like how we send. We can send the sample directly, we can send direct syringe, or we can send this in green top vacuum. But more important, what they ask you question based on numericals. So let us see the normal value. So normal pH is 7.35 to 7.45. Am I audible guys? Audio video is fine? The sample directly. So normal pH is 7.35 to 7.45. So if you see this point after point, we have 35 to 45. So this will be normal PaCO2. Simple. And normal bicarbonate will be 20 26. So these 3 values you have to remember. So what 3 values? pH, PaCO2 and bicarbonate. That's it. So before solving a question of ABG, just remember we have certain question on anion gap. So what is anion gap? Understand this thing. Anion gap is nothing. It is like sodium means positive ion minus sum of negative ion, means chloride plus bicarbonate. As a rule of mathematics, first we have to solve the bracket. So suppose whatever value is given, sodium minus chloride plus bicarbonate. So when you get a value in a range of 6 to 12, we call this normal anion gap. So if you get a value less than 6, we call this lagma. If value is in the range of 6 to 12, we call this nagma. And if value is more than 12, what we call this hagma. Simple. So hagma, lagma, nagma. So they ask you a question like sometime a question based on this formula. So this formula is extremely important. Or sometimes they will ask you where you will see hagma, where you will see nagma. So understand this thing. Hagma is something which is seen in ketosis state. Whenever body is having ketosis, like in a patient of DK. Hagma you can see in a patient of uremia. Uremia means in a patient who is having AKI, means acute kidney injury, or in a patient with CKD. Then you can see this in a patient of lactic acidosis. You can see hagma in a patient of lactic acidosis. You can see this with toxins, and you can see this with salicylate. You can see this with salicylate. You can see this with sharab, means alcohol, and you can see this in starvation. You can see this where in starvation. So this you can remember by mnemonic cults. So S for salicylate, S for sharab, S for starvation. Now try to understand this thing nagma. They ask you nagma where you can see this in diarrhea. In a patient who is having diarrhea. In a patient who is having RTA, means renal tubular acidosis. All the types of RTA, like be it type 1, type 2, type 4, all types of RTA. And you can see this where in ureterosphygmoidoscopy. ureterosigmoidoscopy. This PDF will be shared in your groups. Just listen to me what I am saying, because these are only those topics which are repeatedly asking in exam. Lagma, understand, low. It is seen in a patient with lithium toxicity. And you can also see this in a patient of multiple myeloma. So they ask you sometimes like all are causes of hagma, nagma, lagma. Simple. Okay, now look at the screen. So for ABG we have a rule. If pH and PaCO2 they move in same direction, then disorder is metabolic. If they move in opposite direction, opposite means reverse direction. When they move in reverse direction, then disorder is respiratory. Then what you have to do, you have to see the pH. So this is rule number 1. Rule number 2. So this you can remember by a mnemonic, that mnemonic will be Rome. So what is Rome? Means respiratory you will see opposite direction. Metabolic you will see equal direction. Respiratory opposite, metabolic equal. So respiratory opposite, metabolic equal. Clear? Okay, now third what you have to check, you have to check the pH. Now what you have to check, the pH. So if pH is low, that means if pH is low, that means acidosis. pH is more, that means alkalosis. Simple. So let's solve a few questions. Now look at the screen quickly. pH 7.3 decrease, PaCO2 decrease. So both directions are same. Both are going in same direction, means metabolic. pH is low, that means what we call this metabolic acidosis. Simple. Let's solve few more. Look at this, pH is more. I am going a little fast because this is the revision class. It's not your main class, so we are just trying to preserve your time. pH is more, PaCO2 is less. Normal value of pH 7.35 to 7.45. Now you can see directions are opposite. Opposite direction means it is respiratory, and pH is more, that means it is respiratory alkalosis. Done? Okay, let's see the next one. pH 7.2. You can ask your doubts in your chat box. pH 7.2 means low, PaCO2 80 means more. So again directions are opposite. So you can see opposite means reverse direction is respiratory. Now pH is low. pH low means it is respiratory acidosis. Done? Let's see more. pH is more, PaCO2 is more. Directions are more. Directions are more means this is your same direction, means metabolic. pH is more means this will be metabolic alkalosis. But sometime what they do in exam, sometime they will not ask you this direct question. What they ask you? They ask you question on compensation. Compensation means whenever problem is in the body, then remember lungs will try to compensate, and when problem is in the lungs, then kidney will try to compensate. So that is what we call this compensation. Now try to understand this thing in compensation. Let's see this question first. pH is low. You can see the direction. 7.25. Now PaCO2 is more. So when you see this directions is now opposite. So it is a respiratory problem, right? It's a respiratory problem. Now remember, in a respiratory problem, who will do compensation? Kidney will do compensation. And how kidney will do compensation? Kidney will do compensation by producing bicarbonate. So it is the primary disorder, I will say it is respiratory. pH is low, so it is respiratory acidosis. And in a respiratory case, who will do compensation? Kidney will do compensation. And how it will do compensation? By producing bicarbonate. Now you can see bicarbonate normal value is 22 to 26. Here bicarbonate is normal, it means kidneys are doing nothing. They are not doing any sort of compensation. When bicarbonate is normal, what we call this uncompensated. It is uncompensated. Done? Okay, now look at this. Here. pH is normal. PaCO2 is more. But when you see 7.37, I can say previously it was 7.35 or less than that. So it is towards lower side. So I can say this is towards lower side. So when you see it is towards lower side, if you compare this now, and you can notice PaCO2 is more, directions are now reversed. When you compare this with dotted arrow, then this is a patient of respiratory acidosis. And I told you in respiratory who will do compensation? Kidney will do compensation. So bicarbonate normal value was 22 to 26, but now it is increased. It means kidneys are doing their best, and actually kidney did their best. They have increased bicarbonate to a certain extent that pH became fully normal. And when pH became fully normal, what we call this fully compensated. So this will be fully compensated. Yes, we are revising those topics, difficult topics, which are tend to be mistaken by students. Very very important. इसके बाद और difficult topic ही लूँगा मैं. So I'll take all the difficult topics which are expected to come in exam. Okay, now look at this. pH 7.33. pH is low. PCO2 is more. So primary disorder, when you see it is respiratory, pH is low means acidosis. Now see, bicarbonate is increased, but it have increased, but still pH is not normal. pH अभी भी normal नहीं हुआ है. pH is still not normal. So what we call this, it is a partial compensation. It is called a partial compensation. So this is about your partial compensation. So understand this thing. pH अगर पूरी तरीके से नॉर्मल हो जाए, फुली कॉम्पेंसेटेड. pH पूरी तरीके से नॉर्मल ना हो, पार्शियल कॉम्पेंसेशन. अगर बाइकार्बोनेट बड़ा ही नहीं हुआ, इसका मतलब किडनीज आर डूइंग नथिंग. इट मींस अनकॉम्पेंसेटेड. डन. ओके, नाउ लुक एट दिस. नाउ लेट्स सी अबाउट मेटाबॉलिक एसिडोसिस. सो pH इज लेस, PCO2 35 to 45. So PCO2 is normal, or I can say it is towards decreasing side. So you can see PCO2 is not increased, it means not a respiratory problem. So you can see the compared dotted arrows 38 35 के पास. So 38 35 के पास means towards lower side. You can see same direction. So what we call this metabolic acidosis. Now in metabolic problem, who will do compensation? Lungs will do compensation. And how lungs will do compensation? By producing CO2. So now you can see lungs, CO2 is normal, it means lungs are doing nothing. Lungs are doing nothing means metabolic problem में lungs compensate करेगा. अभी lungs कुछ नहीं कर रहा है. So what we call this? We call this uncompensated. Clear? Am I clear, guys? You can ask your doubts in the chat box. I'm ready to answer your doubts. Okay, now look at this. pH 7.37. So pH normal. So when you see pH अगर normal हो गया, they ask you question on compensation. Just remember pH normal हमेशा कब होगा? When it is a fully compensated disorder. तो अगर फुली कॉम्पेंसेशन होगा तभी pH पूरा नॉर्मल होगा. So when you see pH is normal 7.37, or you can see PCO2 is decreased. So 7.35 is near to 7.37. So I can say directions are same, means it is a metabolic acidosis, and that is now fully compensated because pH became fully normal. Okay, let's see one more. pH is low, PCO2 is low, both are low means same direction. Same direction means metabolic acidosis. It is metabolic acidosis. Now you can see PCO2 is changed, but pH is still not normal. pH still not normal. So pH is still not normal. So when pH is still not normal, that means this is a partial compensation. It is called a partial compensation. Done. So this is how we solve a question on ABG. Very very important for your last minute revision. Okay, then they ask you a question on vomiting, means what will happen if a person is vomiting. So understand this thing. So whenever a person is vomiting, so vomiting means it is expulsion of content, expulsion of food content. So inside the stomach what we have HCl. So I am writing HCl like this, H positive plus Cl negative. What else we have? We have sodium ion, we have potassium ion. So these all the things are in the stomach. So whenever a person is vomiting these things out, suppose these things are being vomited, these things are being removed. So what will happen? These all the things are removed. So look at the screen, try to understand this thing. They ask you what will be the electrolyte imbalance. And this question they are asking from past 3 attempts regularly. So because of vomiting, what will happen? You can notice there will be, I will say, hyponatremia, means sodium will be lesser. There will be hypokalemia, means potassium will decrease. Then you can notice hypochloremia and metabolic. Now see, H positive is removed. When H positive is removed, H positive is less, means acidic ion is less. That means it is metabolic alkalosis. Simple. And this question came many times in your exam, and I'm expecting this in this attempt also. So this was regarding ABG. So I hope this is like a simple trick to solve all the question on ABG analysis. Is it clear? Any doubt, guys? You can ask your doubts in the chat box. I am seeing your messages. So ABG is done. Now let's talk about what they ask you, all the important ECG in exam. So let's talk about ECG now. So first try to understand this thing. So in exam generally they give you two types of ECG question. So first is a question which they ask you, that will be a question on arrhythmia, means a question on rhythm disorder, or I can say rate disorder, means they can ask you question either tachyarrhythmias or AV block, means bradyarrhythmia what will have, it will have AV block. Or what they ask you, they ask you generally question on MI, myocardial infarction. So here I am discussing all these. Suppose when you see a question on rhythm or rate, what we have to see. So if you see it's a question on like they are telling you palpitation, so mostly they are asking a question on tachyarrhythmias. So in tachyarrhythmias what you have to see, first thing you have to see is QRS. So when you see QRS, so QRS if it is narrow, so narrow QRS is also called as normal QRS, and this is your broad QRS. So understand this thing, when QRS is narrow, so mostly it is atrial arrhythmia. So it means they are talking about atrial arrhythmia. And when QRS is broad, they are talking about ventricular arrhythmia. So this should be the hack that you should know. So we should focus on QRS. So now try to understand this thing one by one. I'll show you. So this is an approach which I am telling you here. So first thing what we have to see is QRS. So let us see some important ECG. So look at this now, PSVT. So first look at this. In this ECG, what I can comment, you can see this QRS is narrow. So first thing I can comment is QRS is narrow. QRS is narrow, it means it is atrial arrhythmia. So in atrial arrhythmia what we have PSVT, we have atrial flutter, we have fibrillation, we have MAT. But here you can notice something, this RR is regular. RR interval is regular. So when you see a regular RR interval with a narrow QRS, this is ECG of PSVT. So what you can see in this ECG, it is narrow QRS with regular RR interval. So first thing which I am expecting is this thing, PSVT. So in PSVT they ask you how you will manage. So if it is a stable patient or it is an unstable patient. So in stable patient what we do this maneuver called carotid massage. In stable what we do carotid massage. And in unstable patient what we do, we straight away do cardioversion. It is synchronized cardioversion. Now understand this thing, when we are doing carotid massage, understand this thing, if it is not resolving from massage, then the drug of choice in this scenario will be adenosine. So we give 6 mg, 12 mg, 12 mg. So maximum 3 dose we can use adenosine. So this is about PSVT. You can see just here I am telling you how to identify the ECG. Okay, let's look at the next one and try to understand this thing. What you can see. Again you can notice here, you can see a narrow QRS. So when you see a narrow QRS, but here you can see 3 different type of P wave. Look at this, 3 different type of P wave. So 3 different type of P wave means you can notice again here you can see a narrow QRS. And when you see 3 different type of P wave, that means you can see first P wave will be normal P wave. Second P wave you can see it look like a tall P wave, we call it P pulmonale. Possibility is third P wave will look like an alphabet M, we call this P mitral. Or sometimes you can see inverted P wave. So when you see more than 3 different types of P wave, like you can notice here this is first P wave, then you can notice second P wave, and here you can notice third P wave. It is called MAT. MAT means multifocal atrial tachycardia, and in MAT remember there is no role of cardioversion, no role of drugs or cardioversion. We call this multifocal atrial tachycardia. Okay, let's move on to the third ECG. Now look at this. In this you can notice something. QRS is narrow. So there is narrow QRS. But you can notice RR is irregular. Look at this RR. RR is irregular. See once again, you can see QRS is narrow, but RR is irregular, and you can always see QRS. See, let's see here you can see QRS, but there is no P. There is no P wave When you see no P wave, narrow QRS, irregular RR, it is an ECG of atrial fibrillation. It is what we call this atrial fibrillation. In AF, what they ask you two things like how you'll manage. So again, you can see in AF for termination, what we can use a drug called amiodarone or ibutylide. Amiodarone or ibutylide. Then understand this thing. Suppose if it is not, suppose you are using this drug. If it fails, then we can do cardioversion. AF will always have risk of emboli. There will be risk of embolus formation. So what we do here, we start anticoagulant, antiplatelet. So that is about AF, atrial fibrillation, right? This will be 3-year session, Surbi. Okay, now look at this flutter. In flutter, you will see narrow QRS and sawtooth type of P wave. So you can see this is sawtooth pattern of P waves. So when you see the sawtooth pattern of P wave, so flutter is nothing. It is a stage before fibrillation. So when you see a sawtooth pattern, the sawtooth pattern is called atrial flutter. Done. Okay, now look at this. Now in this you can see a broad QRS but regular RR. So when you see a broad QRS with regular RR, so this ECG is for VT. VT means it is for ventricular tachycardia. Ventricular tachycardia. So I am discussing all the important ECG. Okay, now look at this. Sometime in VT, what they give you fusion beat and capture beat. Now try to understand this thing. You can see here a broad QRS, but in between you can see this P and QRS, they fuse with each other. When they fuse with each other, we call this fusion beat. So you can see broad QRS, all of a sudden you will see a normal QRS. That means all of a sudden heart is capturing the rhythm. That is called capture beat. So sometimes you can see fusion beat, capture beat. So this capture beat, fusion beat, these are seen where? These are seen in patient of VT. Okay, now let's look at this. This is ventricular bigeminy. So sometimes they ask you a question on ventricular bigeminy. So bigeminy, trigeminy, these are seen because of digoxin toxicity. Digoxin toxicity. We call this Gemini rhythm, bigeminy, trigeminy. Okay, now look at this. You can see a broad QRS. This is first type of QRS. You can see this is second type of QRS. This is third type of QRS. And when you see more than 3 type of QRS, what do we call? We call this torsadis. This is torsadis. In torsadis, how you will manage? In torsadis, what you will give? In torsadis, we give MgSO4, magnesium sulfate. So this is about ECG of torsadis de Pontis. Okay, let us see another one. This is, you can see, when we cannot identify anything. So when we cannot say, isko bolte hain puchod pattern. Means you cannot see it is what it is, P or QRS or what is it, whatever it is, we don't know. We cannot comment it is P or QRS. We call this unidentifiable QRS. This is ventricular fibrillation. So whenever we see unidentifiable P and QRS, we call this ventricular fibrillation. So this time I am expecting this in your exam. Done. Okay, now look at this. In hypertensive patient, what you can notice like sometimes they ask you strained pattern. They can ask you like patient will have strained pattern. And for LVH, for left ventricular hypertrophy, what we have to do, we have to calculate. So how we calculate something, we have to calculate like it is based on your hypertrophy criteria. So we have so-called criteria for this. So how we calculate? So we see it is called like SV1 means S, this S length in V1 and RV6. So length of R. So now see QRS is what? What is this QRS? You can see negative wave before R is Q. Then you can see positive wave is R, and after that one more negative wave is S. So this is Q, R, S. So S is going down. So you see length of S in V1 plus what you see length of R in V6. If it is more than 35, then this is suggestive of LVH. It is suggestive of left ventricular hypertrophy, and this is seen in those patients who are having untreated hypertension. So LVH is a feature of uncontrolled hypertension. Uncontrolled hypertension. Okay, now understand. They ask you about TMT. TMT means treadmill test. In treadmill test, what we do? So first, this is like a patient before TMT, and when you see the same patient after TMT, you can notice ST depression. So you can see depression where in lead 1, lead 2, lead 3. So when you see ST depression in more than 3 lead, when you see ST depression in more than 3 lead, this is suggestive of ischemia. It is suggestive of ischemia when you see ST depression more than 3 lead. So this is before TMT and this is ECG after TMT, or I can say during TMT. Simple. Okay, now look at this. Now let's talk about block. So when you see in block, in AV block means these are bradyarrhythmias. So first of all, you have to see PR interval. So look at the screen and try to understand this thing. This is P, starting of P and starting of R. You can see increase in PR interval, but no missed beat. So increase in PR interval, but no missed beat. No missed beat, or I can say no drop beat. It is a feature of first degree AV block. PR is increased, but no missed beat or drop beat. Now look at this. When we say second degree AV block, look at this again. So you can see increase in PR, and you can see here drop beat. Increase in PR, and along with this, what you can notice drop beat. This is your drop beat. PR progressively बढ़ रहा और drop beat आ गई, तो उसको बोलते हैं Mobitz 1, or we call this Wenke-Bach phenomena. Now look at this. Increase in PR, then there is a drop beat. Here what you can see? Here you can see a constant PR. You can see a constant PR with drop beat. It is your Mobitz 2. This is Mobitz 2. And whenever understand, you will see AV dissociation. So what is AV dissociation? Understand this thing. You can see a constant P and constant R. So when you see the length of R, this length of R, and you can see similarly length of P. So when you see a constant PP and you see a constant RR, constant PP and constant RR, it is called as third degree, or what we call this AV dissociation. AV dissociation. So these are the different types of block that we see. Very, very important. These are different types of block that we see. Done? Am I clear, guys? Okay, now let's talk about, this is again in ECG you can see narrow QRS. So let's see, first you can focus is narrow QRS, and when you see narrow QRS with irregular RR, see narrow QRS with irregular RR. Now look at this. This is QRST. Again QRST. So there is no P. There is no P wave here. So it is ECG of AF, atrial fibrillation. It is your atrial fibrillation. Done? Okay, now moving to next one. Now let's talk about ECGs of MI which they ask in exam. So first, whenever you see an ECG of MI, it's quite easy. You can see the ST segment changes. You can see ST segment elevation or ST depression. So here, like starting, we will start with the lead one. We always check at the lead one. So first look at this. You can notice in lead V1, in lead 1, what you can notice is ST elevation here. Then lead 2 is quite fine. Then you can notice AVR is okay. AVL में देखो, you can see an elevation in AVL. AVF is fine. आगे देखते हैं, V1 में दिख रहा है, you can see in V1, you can see in V2, you can see in V3, you can see in V4, even V5, V6. So you can notice like lead 1 AVL V1 to V6. So it is, I can say lead 1, then I can say AVL, then V1 to V6. So it start with V1. So basically, understand this thing in V3, V2, V3, V4 and wall. It's anterior wall MI. So it is basically what we call this extensive anterior wall MI. It is extensive anterior wall MI. Okay, let's talk about the next one. Look at this now. Next one, you can see there will be changes in lead 1. So lead 1 में है और किस में you can notice AVL में. Lead 1 AVL. So this will be your lateral wall MI. So this will be your lateral wall MI. Now how to remember this wall? Look at the screen. This wall you can remember like V1, V2, V3, V4, V5, V6, 7, V8, V9. So when you see changes in lead V1, V2, it is your septal wall MI. And when you see in V2, 3, 4, this is your anterior wall MI. Anterior wall MI. In V5, V6, you will see a lateral wall MI. And this will be your posterior wall MI. So this you can remember by mnemonic SALP. Clear? Okay, now let's talk about next one. You can clearly see here. You can see changes in lead 2, lead 3 and lead AVF. So 2, 3 AVF. So this is telling you about, this is your inferior wall MI. Inferior wall MI. Done? Okay, now look at this. Try to understand this thing. Here what you can see. So lead 1 is fine, 2 is fine, 3 is fine. Then you can notice where in V1 you can see some changes. In V2 you can see classical changes. V3 you can see classical changes. V4 is there. So you can see V1 to V4. So what we call as V1, 1, 2, 3, 4. It is anteroseptal MI. Anteroseptal MI. Okay. Okay, now look at this. You can see in lead 1. So in lead 1 you can see. Then you can notice AVL. AVL में भी changes है. AVL में changes है. Where else you can see? Then you can see 2, 3 is fine. AVF is fine. Then you can notice there will be changes where in V3. In V3 you can see changes. V4 में भी है, V5 में भी, V6 में भी. So what do we call this? So anterior तो involvement हो गया. Anterior तो हो ही गया. लेकिन साथ में क्या? What you can see? V6 भी हो रहा है. So it's called anterolateral MI. Even this much nobody asks you. So just remember this thing which they ask in exam. SALP. और SALP के अलावा क्या रखना है? 2, 3 AVF. 2, 3 AVF means inferior MI. So this will be about the MI which they ask in exam. So I hope I have discussed the major ECGs. Now let's talk about the approach of pattern which they ask in different antibodies. So you can see different antibody will have different pattern. So let's see this. They ask you what are the antibodies. So ANA is the antibody that we do for screening purpose. ANA is the antibody. It is done to screen most of the autoimmune condition. Anti-dsDNA, it is most, I can say it is specific antibody for SLE. So ANA is done for screening autoimmune disease. So whenever you want to screen some autoimmune disease, अगर आपको autoimmune disease को screen करना है, then what we do ANA. Anti-Smith considered most specific antibody. It is something which is most specific for SLE. It is most specific for SLE. Anti-Rho and anti-La. These both are seen in a patient of Sjogren syndrome. Just remember anti-Rho. Anti-Rho और कहाँ होती है? कोई बताएगा? Anti-Rho is also seen in neonatal SLE. Neonatal SLE. Anti-TTG and anti-endomysial. Anti-TTG endomysial, where we see these are seen in a patient of celiac spro. Anti-thyroid receptor antibody, thyroid stimulating immunoglobulin, long acting thyroid stimulating antibody. These are seen where? These are seen in a patient of Graves disease. Anti-topoisomerase. Topoisomerase का commercial नाम होता है anti-SCL70. We also call this anti-SCL70. and this is seen where? कहाँ दिखेगा? It is seen in a patient of systemic sclerosis. Systemic sclerosis means it is systemic form of scleroderma. Okay, let's see few more things about SLE. This is butterfly rash. You all know like how butterfly rash present. SLE में और क्या पूछते हैं? C1q inhibitor deficiency, TREX gene, and a new MCQ like there is increased risk of SLE with Klinefelter syndrome. In those patients who are having Klinefelter syndrome, they will have increased risk of SLE. So this is about your SLE. So butterfly rash आजकल कोई नहीं पूछता. So just we are talking about those topics which are expected to come. Okay, now look at this. Lupus nephritis means SLE nephritis. So we have different type. Just what you have to remember is most common type which is diagnosed as type 4, and this type 4 is called as DPGN, diffuse proliferative. This is most common type diagnosed. And in DPGN, what we see in DPGN, the classical feature what we see is there will be wire loop lesion. There will be wire loop lesion, and there will be deposition of a lot of things. What we call this full house effect. So they can ask you this type of question in your path exam, in your path MCQ. So इसको क्या बोलते हैं? We call this full house effect. Done? Full house effect. Okay, now coming to drug-induced lupus, how it is different from simple SLE. Drug-induced lupus antibody is antihistones. So which antibody you will find? Antihistone. And here remember, male is to female ratio is same. So male is to female ratio will be same, 1:1. Antibody is antihistone, and this drug induced will not affect kidney and brain. Now they ask you which drug, so you all know this is ship drug, like sulfonamide, dapsone is also coming in sulfonamides, hydrolyzine isoniazide, procanamide, PTU, phenytoin. So these are ship drugs which can cause drug induced SLE. Okay, so these are the list of antibody which we see in SLE. So just quickly revise. So anti-Smith antibody, this is most specific. Anti-dsDNA, it is something which correlate with activity. It is something which correlate with activity. Antihistone in drug-induced lupus. Anti-Ro Jogren. But here I am talking about SLE, so that means it will be neonatal SLE. Neonatal SLE. Anti-ribosomal P. Anti-ribosomal P. So P for psychosis. It will cause psychosis in SLE. CNS symptom. Understand this thing. CNS symptom in patient. This will occur because of anti-neuronal antibody. Anti-platelet antibody. What it will cause? Antibodies against platelet. It will cause ITP in SLE. Anti-erythrocyte will cause AIHA in SLE. And anti-U1 RNP, it will cause mixed connective tissue disorder. We call this MCTD. Okay, now sometimes they ask you clinical case on Apla syndrome. So just remember, in Apla they ask you clinical case like patient will have recurrent spontaneous abortion. So there will be like 1 or more unexplained death of fetus after 10 weeks, or 3 or more recurrent abortion, or 1 or more premature birth because of any reason. Then you can notice the classical rash in Apla syndrome. This rash is called as livedo reticularis. This rash is called as livedo reticularis. We call this livedo reticularis. So this is about Apla syndrome. They ask in exam a clinical case. Now coming to scleroderma, they ask you generally like we have 2 forms, systemic form, or what we have localized form. The main cytokines, it's TGF beta. This is responsible for causing fibrosis in different organs, and this TGF beta, remember, it will cause fibrosis in your pulmonary artery, and that can lead to pulmonary artery hypertension. Pulmonary artery hypertension, and this is the cause of death. PH is the cause of death in a patient of scleroderma. Okay, now look at this. Most common lung finding will be non-specific intestinal pneumonitis. Then these are some other findings you can notice. There will be Raynaud phenomena, you can see digital ulcers, you can see scleroderma crisis. But what they ask in your exam is, this is color change sequence in Raynaud. So let's look at this. P means pale, cyanosis red. We call this PCR. White, blue, red. Pale, cyanosis red. Then you can see there will be like microstomia, small opening of mouth. You can see the nose will be like a beak-like nose. Then there will be calcium precipitation in hand. We call this calcinosis. Calcinosis. These are small telangiectasia. Calcinosis. Then what you can notice like patient will have sclerodactyly, means absence of fold. जो हमारे हाथ पर fold होते हैं, fold गायब हो जाते हैं, sclerodactyly. Again you can see like a tight skin, small opening of mouth or microstomia. Then there can be acroosteolysis. This part of bone is about to break. तो पहले क्या होगा, डिजिटल अल्सर्स होगा, acroosteolysis. And patient will develop a leather like skin. There will be a leather like skin. So these are all the changes where in scleroderma. So in a nutshell I have revised everything about scleroderma. Okay, so scleroderma, remember एक क्वेश्चन ये भी आता है, फर्स्ट टेस्ट इन scleroderma, फर्स्ट टेस्ट विल बी आना, एंड वेन एवर पेशेंट विल हैव लाइक सिम्टम ऑफ scleroderma प्लस पॉलीमायोसाइटिस. scleroderma के साथ में अगर पॉलीमायोसाइटिस के सिम्टम है, scleroderma प्लस पॉलीमायोसाइटिस, then what we see anti-PMS here. Then now anti-RNA polymerase 3, it is for scleroderma renal crisis. So these are the antibody that we see in scleroderma. Mixed connective tissue disorder, when you see two or more autoimmune disease in one patient, एक ही patient में अगर आपको दो या उससे ज़्यादा दिखती है, उसको बोलते हैं MCTD. We call this MCTD. Clear? Okay, now try to understand. We have Sjogren syndrome. So they ask you Sjogren syndrome, like there will be lymphocyte infiltration. तो यहाँ पर आप देख रहे हो lymphocyte जमा हो जा रहे हैं. So these are lymphocyte infiltration. Then this is like a test. So this is lymphocyte infiltration in your parotid gland in a patient of Sjogren syndrome. Then you can see this is a test that we call Schimmer's test. We call this Schimmer's test. So Schimmer test किसके लिए करते हैं? It is for dry eyes. It is for dry eyes. So Sjogren syndrome patient, they should avoid using excessive mobile phone, sitting in front of the cooler or going into smoking lounge, because that can lead to more dryness. Now dermatomyositis, polymyositis, they ask you question like, this is a type of rash we see in the periorbital area. We call this heliotropic rash. Heliotropic rash. And you can see these are the papules in the skin. We call them Gottron papules. These are papules in the knuckles area, Gottron papules. Now remember, dermatomyositis, polymyositis, only difference is dermatomyositis will have skin involvement, and both will have involvement of proximal muscle. So there will be proximal muscle weakness. Proximal muscle weakness. Most common inflammatory myopathy in elderly. Elderly में कौन सी होती है? In elderly it will be inclusion body myositis. Inclusion body myositis. And this is something which is resistant to immunosuppressant. With autoimmune disease, most common myopathy is polymyositis, and ocular muscles are spared. Now try to understand. We have an antibody called anti-155-140. This is something which is seen in dermatomyositis, and that is associated with malignancy. Differential diagnosis will be fibromyalgia. Now coming to ankylosing spondylitis, what they ask you a new question like, we have a new drug called secukinumab. Then what else they can ask you? They ask you clinical case like a patient is having back pain, and for this what we do a test called Schober's test. So patient will have back pain, investigation of choice will be MRI, but in X-ray you will find few classical findings. So this is your bamboo spine. So this is bamboo spine, and sometimes what you can notice a white line. We call this dagger sign. It is called dagger sign. So these are all the MCQs on ankylosing spondylitis. Psoriatic arthritis, understand this thing, patient will have current psoriasis or family history of psoriasis. So you can see there will be dactylitis, so fingers become swollen. Such fingers are called sausage digits. When fingers become swollen, we call them sausage digits. Then you can see there is telescoping of toes, arthritis mutilans, and enthesitis. Then this is something called Sappho syndrome. Sappho syndrome, it came once in exam, in NEET PG, not in your exam, but it can be asked in future. Synovitis, acne, pustulosis, hyperostosis, osteitis. Okay, now reactive arthritis means can't see. Can't see means there will be conjunctivitis. Can't pee means urethritis. Can't dance with me means that is your arthritis. So then patient can develop this rash in the soles. We call this scleroderma beloregica, and there can be a penile inflammation that's called succinate balanitis. So this is about reactive arthritis. Okay, now they ask you question on gout patients. So gout, the differential diagnosis of gout means will be any type of arthritis. So remember, patient is having gout. So generally there are two common trigger. First trigger is alcohol. Second will be aspirin. So 2A, alcohol and aspirin. These are common triggers. Then in gout you can see there is formation of tophi. You can see this tophi, and tophi most common site of tophi will be olecranon. Tophi most common site will be olecranon. It can be in finger pad, but most common will be olecranon. Then in gout you can see this sign. This sign is called Martel sign. We call this Martel sign or G sign. It is seen in gout patient. Okay, now coming to acute gout, chronic gout, how we manage. So in acute gout we have three options. In acute gout we have three options. So first option will be we can use NSAIDs. Second option is what we can use. We can use steroid. And third option is we can use a drug called colchicine. We can use a drug called colchicine. In chronic gout, understand, in chronic gout what we have option like we have to remove the uric acid. So for this what we can use xanthine oxidase inhibitor like allopurinol, or we can use febuxostat. Sometimes we can use uricosuric drug, like we have drugs like sulfin, pyrazone, benzabromarone, probenecid. The last option, understand this thing, in case of refractory gout or gout due to tumor lysis syndrome, we use rasburicase. So these are the management of chronic gout. Okay, we differentiate gout from pseudo gout. So understand this thing, crystals in gout. These crystals are made up of MSU, monosodium urate. In pseudo gout, they are made up of calcium pyrophosphate. Am I clear? Okay, now coming to shape of the crystal. Shape of the crystal in gout, it will be a needle shape. In pseudo gout, it will be rhomboid shape. It will be rhomboid crystals. So these are negative birefringence. These are positive birefringence. Most common site of gout, it will be first MTP, first metatarsophalangeal joint. In case of pseudo gout, it will be knee joint. It will be knee joint. Now coming to treatment, how we are going to treat. So in gout, how we treat? In gout, we give same drugs which we have discussed already. Like in acute attack, I will use NSAIDs. Drug of choice in chronic case, what we use allopurinol. And remember, NSAID of choice will be indomethacin. Now they ask you in pseudo gout what we use. Pseudo gout is an acute condition, so we will use NSAIDs. So this is about pseudo gout and gout. So you can see monosodium urate crystals and calcium pyrophosphate. Okay, now they ask you polarized microscopy is used for monosodium urate, calcium pyrophosphate and calcium oxalate crystals, and low dose aspirin can precipitate gout. Remember, high dose is protective. High dose will be protective. Now coming to Charcot joint, this image came in your exam. So remember, Charcot joint is neuropathic joint, or I can say painless destruction of joint. The most common cause for this will be diabetes. The most common cause of Charcot joint will be diabetes, and they ask you the Charcot joint, what is another name? So we also call this chiroarthropathy. Charcot joint is also called as chiroarthropathy. Okay, now look at this. Like you can see, Abraham Lincoln had this condition: chromosome 15, tall height, fibrillin mutation, autosomal dominant condition, pactus carinatum, ectopia lentis, mitral valve prolapse that can lead to MR, and dilatation of ascending aorta which can lead to aortic dissection. And because of aortic dissection, the patient will die. So they ask you two things. First is most common problem in Marfan will be musculoskeletal defect. And second thing, what they ask you cause of death. Cause of death is aortic dissection. So these are all the MCQs on Marfan syndrome. Okay, now rheumatoid arthritis, they ask you mostly question on different type of arthritis, I can say finding which we see. You can notice like two important finding. First is swan neck. Swan neck is flexion of your DIP. This is DIP, and hyperextension of PIP. Then we have bottleneck, that will be flexion of PIP, and hyperextension of DIP. So this is your swan neck, this will be your boutonniere. Then you can see the swan neck, boutonniere. Other than this, remember the question how they start, they ask you patient will have joint pain, especially in the smaller joint, and along with morning stiffness. Joint pain, along with this you can notice morning stiffness, and this will last for more than 45 minutes. This will last for more than 45 minutes. So this is about your rheumatoid arthritis. Now more important, what they ask you like what are extra articular manifestation, joint के अलावा और क्या क्या प्रॉब्लम होती हैं. So understand this thing. Extra articular means, now see, most common will be this nodule which we can find. There can be kidney involvement, so just I am writing here, there can be MGN, there can be secondary amyloidosis, secondary को क्या बोलते हैं, और AA amyloid, secondary or AA amyloid. Then patient can develop cardiac disease, and that is the cause of death. So death occur because of heart disease. There can be pulmonary involvement, there can be pleuritis, it can lead to pleural effusion. So just remember, only MCQ part I am writing. Which effusion? It is exudative effusion. एक बार इस वीडियो को 1.5x पे सुन लेना एग्जाम से पहले. That's it what I want. Then you can notice there will be xerostomia, periodontitis. Then patient can develop vasculitis. Even this question came, most common anemia. Most common anemia will be normocytic normochromic anemia. Normocytic normochromic anemia that we see in a patient of rheumatoid arthritis. Done. Okay, which type of effusion you will see? You will see exudative effusion. Most common valvular disease will be MR. Then you can see this is IgM against IgG, and this is what we call, इसी को बोलते हैं rheumatic factor. Iritis is absent. Iritis is not seen. Okay, approach is same. We start with methotrexate. No improvement with methotrexate, then we can add leflunomide, or we can add sulfasalazine. So this is like 3 DMARD we add. If no improvement coming, then we add biologics. So biologics means these are basically drugs that act on TNF. These are those drugs which act on TNF. We call them biologics. Simple. Okay, now coming to sarcoidosis, they ask you most common organ, lung. Then we have 3 bodies which we can see in sarcoidosis. So first is Schaumann body. Schaumann body. So these bodies you can remember by first 3 letters of sarcoid. Schaumann body. Second is asteroid body. Asteroid body. Then we have residual body. Then you can see lupus pernio. This will be a rash which look like SLE. Then there can be fever, parotid enlargement, uveitis, and facial nerve palsy. Just remember, this facial nerve palsy is bilateral. You can see sometime erythema nodonosum. ACE level is more, calcium level is more. Gallium scan will have a sign called Panda sign. We can do Queem test. Then in bronchoalveolar lavage you will see CD4 is to CD8 ratio. It will be more. Then we have Skadden scoring system and Garland sign. Garland sign is also called as 1, 2, 3 sign. We call this Garland sign or 1, 2, 3 sign. Okay, now look at this most common cranial nerve. It will be 7th nerve. Increased calcium because of increased vitamin D production within granuloma. And when always remember, whenever you see calcium, this calcium is inversely proportional to QT. So when patients are having hypercalcemia, you can see QT will be short. There will be QT shortening. So this is your case-shutting granuloma. This is a rash called lupus pernio. We call this lupus pernio. And this you can see, we call this caseating granuloma, and here you can see this is Garland sign or 1, 2, 3 sign. This is your Garland or 1, 2, 3 sign. Okay, now try to understand. They ask you question on vasculitis. Just remember, temporal arteritis, it is MCQ which I am expecting from this topic is, it is something which is associated with polymyalgia rheumatica. It is something which is associated with polymyalgia rheumatica. This is polymyalgia rheumatica. Takayasu is always in a younger patient, less than 40 or 50-year-old. You can see investigation of choice in this condition, it will be CT angio. And patient will have like a radio femoral delay. We also call it pulseless disease. Now look at this PAN. PAN is a type 3 hypersensitivity. So type 3 means you will find immune complex. There will be immune complex. And cause of death is GIT ischemia or GIT infarction. It's about polyarteritis nodosa. Now Kawasaki disease, even like it's an examiner favorite, came multiple times. Just remember, even last attempt this was a question. It is non-purulent conjunctivitis. It's not a purulent, it's non-purulent. There is increased risk of MI or aneurysm, myocardial infarction, aneurysm. Strawberries are seen in many places. Strawberry gums, where you will see strawberry gums, it is seen in Wegener's granulomatosis. Strawberry tongue you will see in Kawasaki. And scarlet fever. Strawberry gallbladder you will see in cholesterosis. And strawberry nose you will see in rhinosporidiosis. There is one more, strawberry vagina, that we see in trichomoniasis. So these are different types of strawberries. This is Berger disease. Just remember, Berger disease is also called this thromboangiitis obliterans, and patient will have a classical history of heavy smoking. There will be a history of heavy smoking. And this is start with artery, then it will go to vein, then it will affect nerve. So means here you can see nerve symptom as well. Okay, this is Wegener. So in Wegener, just remember two things which they are asking nowadays. So I am changing the Wegener spelling to Wegener's. C. Wegener C. C for cavitation. Just remember, the classical feature will be cavity formation. Now understand this thing. Other than this, you can notice like patient with Wegener's, the drug of choice will be cyclophosphamide. Cyclophosphamide. Then remember, like patient will have a depression in the nose. This is called as your saddle nose. Saddle nose. Okay, examiner favorite HSP. We also call this IgA vasculitis. इसका दूसरा नाम जो होता है, that will be your IgA vasculitis. It is a most common vasculitis in children. You can see a palpable purpura and colic abdominal pain. So they can ask you sometime image-based question. Churg-Strauss syndrome will have a certain triad. So it is something like where patient will have skin lesion, mononeuritis, eosinophilia, and something because of this, it is something that mimic asthma. It is something that mimic asthma. So in Churg-Strauss syndrome, understand this thing. Something is mimicking asthma, we have to treat like asthma. Antibody will be Priyanka. Microscopic polyangiitis, just remember the new name, leukocytoclastic vasculitis. Basal disease will have recurrent oral ulcers, recurrent genital ulcers. Then you can see pathology test, HLA is B51. So this is pathology test that we do for Behçet syndrome. Okay. Mixed cryoglobulinemia is something that is associated with hepatitis C. Done. Okay, now let's talk about endocrinology. So you can see like this is Ernst Starling. Starling coined the term hormone. He was the person who increased your syllabus. First hormone was secretin, but most studied or most researched hormone is insulin. Now coming to hormone of cuddling, cuddle chemical or hormone of love, this is your oxytocin. And a hormone which increase your desire to kiss, this is your kisspeptin. So these are some hormones which they ask in exam. Okay, it can be amino acid derivative like catecholamines, thyroid hormones, catecholamines, epinephrine, norepinephrine, dopamine. It can be small peptide, it can be large peptide like insulin, PTH, it can be steroid, cortisol, estrogen, it can be vitamins, means vitamins A and D. Hormones, they will have receptors, so most hormones they will have receptor where? In the cell membrane. Vitamins means vitamins A and D, and thyroid hormone. So they will have receptor where? In nucleus. So look at this, these vitamins A and D, so they will have receptor where? In the nucleus. And steroid and gonadal hormone, they will have receptor in the cytoplasm. So they ask you sometimes question on receptors. Now what they ask you like what are the hormones released from different endocrine glands. So starting first with pituitary. So from anterior what we have flat pig. From anterior we have flat pig. What is flat pig? FSH, LH, ACTH, TSH, prolactin, growth hormone, flat pig. Now coming to thyroid. Thyroid gland will reduce T3, T4 and calcitonin. T3, T4, calcitonin. Then we have pancreas, like alpha cells will produce glucagon, beta cells will produce insulin, delta cells somatostatin, gamma cells VIP, epsilon cells ghrelin. Ghrelin will increase your appetite. Contrary to this, we have another hormone called leptin. Leptin will decrease your appetite. Now coming to adrenal gland, we'll discuss this in detail. So these are other glands which are producing some sort of hormone. So most common site of metastasis in pituitary. So remember, it will be posterior pituitary. It will be posterior pituitary, and most common manifestation of this. What will be most common manifestation whenever anything is going into pituitary? So most common manifestation of this will be diabetes insipidus. So in pituitary we have acidophilic cells or basophilic cells. Out of this, remember, most abundant are cells called somatotrophs, and the somatotrophs will produce growth hormone. Like lactotroph will produce your prolactin. So most abundant will be somatotroph. So sometimes they ask you question like all are basophilic cells except. So pituitary adenoma we have, so you can say this pituitary adenoma. So out of this I can say like most common will be non-functional microadenoma. Most common will be non-functional microadenoma, but if it is not in the option, then answer will be prolactinoma. तब आंसर क्या होगा? prolactinoma. This is about pituitary adenoma. Now they ask you like how we approach a patient of prolactinoma. So fasting prolactin level, when it is more than 100, this is suggestive of prolactinoma. But more than 250, this is definitive of prolactinoma. So how we make a diagnosis based on MRI? Differential diagnosis will be Rathke cyst, craniopharyngioma. Okay, now coming to hypopituitarism, we do a test called insulin arginine challenge test. And suppose a person is having pan hypopituitarism, means all the hormones are decreased. So first hormone to fall, सबसे पहले क्या होगा? First hormone to fall, this will be which hormone? Anyone? सबसे पहले कौन सा hormone fall होगा? It will be your growth hormone. And first hormone you will supplement. Which hormone you will give to patient? Because when flat peaks, okay, ACTH will also go, so we have to give cortisol. And after cortisol we have to give T3, T4. Okay, they ask you question on acromegaly and gigantism. For both the case, most common cause will be growth hormone secreting adenoma. Growth hormone secreting adenoma. So for screening, what we have a test called IGF-1 level. For confirmation, we do OGTT, but investigation of choice will be MRI. Now coming to treatment, what we do? We give pegvisomant, we use landiotide, which came in exam, we can use bromocriptine, cabergoline. Acromegaly will increase the risk of diabetes mellitus, not a diabetes insipidus. Clear? You can ask your doubt, guys, in the chat box. Okay, now coming to approach and treat. So screening, what I told you, we have IGF-1 level. These are the MCQs which came in exam. For confirmation, what we do? OGTT. To localize the tumor, what we need MRI. So this is about your acromegaly. Done? Okay, now look at this. They ask you question on obesity. So see, Prader-Willi, Lawrence-Moon-Beadle, Cohen syndrome, they all are having obesity. Carcinoid will not have obesity. So let's look at this. These are certain genetic conditions which are associated with obesity. So they ask you an exam, all except question. All are associated with obesity except. So all except type question of that. So there are substances that increase appetite and substances that decrease appetite. So just remember MSH, leptin, insulin, these are those which decrease your appetite. Neuropeptide Y, AGRP is a gout related peptide, MCH, orexins, ghrelin, these are the ones which will increase your appetite. Now coming to insulin levels, they are increasing obesity. So they ask you like we have different type of obesity and how we manage this. So like you can see class 1 obesity like 30 to 35. So the treatment is exercise. Class 3 obesity, here we can recommend surgery. Surgery means which surgery? Bariatric surgery. What they ask you, what you will do in class 2. In class 2, when BMI is 35 to 40, suppose if it is affecting your cardiovascular system, it's causing dyspnea, suppose it's affecting your heart or lung, if it is causing some disturbance in your day-to-day activity, then you have to do surgery. Otherwise, remember, it can be done by lifestyle modification as well. Simple. Okay, now they ask you question on anti-obesity drugs. So we have phentermine, lorcaserin, orlistat, bupropion, naltrexone. Then these are the tirzepatide, your Monjaro, liraglutide, and this is your favorite which is trending in YouTube, Instagram, Ozempic. Okay, now coming to polyuria. Suppose if you see a question on polyuria. So polyuria, remember, first of all we have to rule out diabetes mellitus. But diabetes mellitus will have polyuria, polydipsia, weight loss. If you see polyuria is there but glucose is normal, in that case we have to see urine osmolality. If it is less than 300, then we check plasma ADH level. If it is more than 1, then it is nephrogenic. If it is less than 1, then it could be central. In MRI, if this bright spot is present, it could be primary polydipsia. So mainly they ask you to differentiate SIADH from diabetes insipidus, and how we can differentiate. So we can differentiate this based on few parameters, like they ask you question on urine osmolality, plasma osmolality, urine sodium, plasma sodium. And what they ask you question on increase decrease. So let's understand this thing. SIDH will have scanty urine, less urine. Less urine means that urine will have more solute, means urine osmolality is more. It means urine sodium is more, solids are more, because there is water reabsorption. ADH means it is causing anti-diuresis, means against the diuresis. So patient will have water reabsorption. This water, what this water will do, this water will dilute everything. So in the plasma everything will be diluted, so plasma osmolality will be lesser, plasma sodium will be lesser. So patient male complaint you can notice is he will have hyponatremia. Coming to diabetes insipidus, watery urine, पानी यूरिन आ रहा है, पानी आ रहा है तो यूरिन में सॉल्यूट कम होंगे, तो यूरिन ऑस्मोलैलिटी विल बी लेसर, urine sodium will be lesser. Then you can notice plasma osmolality will be more, plasma sodium will be more. So these are the changes which they ask in exam from urine or plasma osmolality of diabetes insipidus or SIDH. Okay, now we have a criteria, just remember the name, it is Barter-Schwartz criteria for SIDH. Now look at this, what they ask you physiology based question, यहाँ से physiology का question आता है. So we have different glands, so just remember glomerulosa, fasciculata, reticularis. So these are three parts, so glomerulosa, fasciculata, reticularis. So go find rest. Then we have make good studies. Go find rest, make good studies. Glomerulosa, fasciculata, reticularis, mineralocorticoid, glucocorticoid, and sex steroid. Mineralocorticoid means it is your cortisol. Then we have glucocorticoid means this will be your, mineralocorticoid means your aldosterone. Glucocorticoid means your sex steroid, means your cortisol, and this will be your sex steroid. So these are the hormones. So sometimes they ask you image based, sometimes they ask you direct question in exam. Okay, now Cushing syndrome, what they ask you round moon like face, lemon on stick appearance. Then you can notice there will be like purple stria, easy bruising, or this purple or violet stria in the body. Approaches midnight serum cortisol we can check, but to differentiate ACTH dependent and ACTH independent, what we do a low dose dexamethasone suppression test. Obesity, alcohol, depression, PCOD, metabolic syndrome. So understand this thing, obesity, alcohol, depression, PCOD, metabolic syndrome. So these conditions, understand this thing, these conditions what they can cause a condition called pseudo-Cushing syndrome. They can mimic Cushing. We call this pseudo-Cushing. Done? Okay, now Cushing most common cause of Cushing will be exogenous, paraneoplastic cause, or I can say ectopic cause. It will be small cell lung cancer. Most common cause will be exogenous. Most common cause in elderly. Most common cause in elderly will be pituitary tumor, and this is adrenal gland means it is due to adrenal tumor, that is it is due to adrenal adenoma. It is due to adrenal adenoma. Okay, now try to understand. They ask you question on Addison disease. Most common cause will be autoimmune adenoitis, which can occur because of TB. Most common cause is TB. Sometimes it can be due to HIV, histoplasma, Neisseria, polyglandular autoimmune syndrome, schistosomia. Then the classical finding, you can see there will be like hyperpigmentation increase, and this hyperpigmentation increase, it is because of increase in level of ACTH. So ACTH will have your MSH like action, and that can increase your pigmentation. So you can see classical hyperpigmentation increase. So Osama bin Laden was having this condition, Addison disease. Okay, now coming to pheochromocytoma. In pheochromocytoma, question कहाँ से पूछते हैं? They ask you question based on diagnostic part. So diagnostic part means they ask you screening test. Then they ask you which test you will do for confirmation. So for screening, for confirmation, then they ask you what is radiological investigation of choice. Fourth thing, what they ask you like suppose if it is like an extra adrenal, now what you will do? Extra adrenal अगर होगा तब आप क्या करोगे? So screening के लिए what we have plasma metanephrin, we have urinary metanephrin. For screening we have urinary metanephrin and VMA level. But if both are given, choose urinary metanephrin. For confirmation, what we do? We do plasma metanephrin. Radiological investigation of choice will be MRI abdomen, but MRI is slightly better than CT. If it is extra-adrenal, so for this what we do DOTA TET scan. But अभी भी आपके एग्जाम में DOTA TET scan लोग पूछ नहीं रहे. So what they are asking? They are asking question on which scan? They are asking question on MIBG. Then we can do an old test called clonidine suppression test. So these are also all the MCQs on pheochromocytoma. These are all the MCQs which they ask on pheochromocytoma. Done? Okay, now understand this thing. They ask you all men are not the same. They have different type of men. So we have men 1, men 2A, men 2B. So men 1 means 3P. 3P means pituitary, parathyroid, pancreas. Men 2A. Men 2, understand this thing. Here you will see 1M2P. 1M2P means there will be MTC. Then you can see this is 1M, and 2P means parathyroid and pheochromocytoma. Look at this here, what I told you: pituitary, parathyroid, pancreas. Pituitary, parathyroid, pancreas. Pituitary, parathyroid, pancreas. Now another this thing, suppose if I take these two things down, these two things here plus Marfanoid diabetes megacolon, Marfanoid diabetes mucociliaroma, that will be meant to be. And men 4 is a new entity: pituitary, parathyroid, adrenal, renal, reproductive tumor. Clear? Okay, now let's talk about different type of diabetes. We have type 1, type 2, but exam what they ask you like LADA is the type 1 diabetes of adult, latent autoimmune diabetes of adult. So how we make a diagnosis? So normal fasting blood sugar, it is less than 100. Normal I can say post-pandemic it will be less than 140. Normal HbA1c is less than 5.6. HbA1c we write in percentage. Coming to diabetes, it is more than equal to 126, more than equal to 200. HbA1c more than equal to 6.5. So how we say pre-diabetes? So pre-diabetes something that is in the range of 100 to 125, 140 to 199, 5.6 to 6.4. This is pretty. So they ask you question on values, means they ask you question on, like suppose a value is given 180, post pandemic value is 180, what is the diagnosis? So mostly क्या पूछते हैं आपसे एग्जाम में? Mostly they ask you question on pre-diabetes. Okay, now see, ADA recommendation is all patient above 35 should be screened for diabetes every 3 years. हर 3 साल में टेस्ट होना चाहिए above 35. You can notice this is like, now you can see polydipsia, polyuria, weight loss. So polydipsia, polyuria, weight loss, these are 3 classical symptoms that we see in diabetes. Okay, now look at this. Fasting blood sugar means diabetes. BP is more means hypertension. fasting more than 110, it could be diabetes, pre-diabetes. Then you can see obesity, you can see lipid. First lipid means triglyceride, second lipid will be HDL. So diabetes, hypertension, obesity, lipid. So when you see 3 or more than 3 symptoms, it is called as metabolic syndrome. So याद रखना ढोल. So metabolic syndrome means when you see 3 or more symptoms. So this metabolic syndrome is also called as syndrome X. We call this syndrome X. So you can see एक ढोल ये है, एक ढोल ये है. This is metabolic syndrome. So when you see syndrome X plus OSA, obstructive sleep apnea, it is called as syndrome Z. We call this syndrome Z. So this is about metabolic syndrome. Okay, fasting more than 92, 1 hour more than 180, 2 hour more than 150, it is the diagnosis of GDM. GDM is gestational diabetes mellitus. It is for GDM. So these are drugs which can cause diabetes. Most common will be steroid. So these are drugs causing diabetes. These are the drugs that can cause diabetes. Very, very important. Okay, now understand this thing. So they ask you like how we manage. So just remember, insulin is given when HbA1c value is more than 9. So we have different types of insulin like short acting, intermediate acting, long acting. So this is Afreeza and one more Exubera. Afreeza and Exubera, these are two inhalational form of insulin. Inhalational insulin. Now Afreeza is contraindicated in COPD patient, asthma patient, and patient those who are active or heavy smokers. Now understand this thing. They ask you like 50% of a diabetes patient should take diet from carbs, 20-30 from protein, 10-20 from fat. So what we call this medical nutrition therapy. Then we have SBGM, self blood glucose monitoring. Patient should know how to prick themselves and check their own blood glucose level. Then there is exercise, that is what we call 150 minutes in a week. This is the recommendation exercise which we recommend to diabetic patient. Goals will be HbA1c less than 7, preprandial 80 to 130, postprandial less than 180, and BP should be less than 130/80. So they ask you like diabetes patient plus hypertension, then which ACE inhibitor ARB you will prefer? We will prefer telmisartan. Telmisartan is preferred ARB that we use in diabetics. Then very, very important, they ask you question on side effect of OHA. So metformin, starting with biguanide. Biguanide means metformin. So remember, most common side effect is GI upset. Then it can lead to B12 deficiency. It can cause lactic acidosis. But remember what they ask you in exam, most common will be GI upset. Sulfonylureas, they can lead to hypoglycemia. So sometime like question they ask in exam like patient suddenly collapse because of hypoglycemia. They are also hepatotoxic. Macrolides will have same side effect like sulfonylureas. Now coming to thiazolidinedione, like we have drugs like rosiglitazone, pioglitazone. These are those drugs which will have slight increased risk of bladder cancer. CA bladder means bladder cancer. Alpha glucosidase inhibitors, so understand this thing, these are those drugs which can lead to constipation, sometimes they can lead to a secretory type of diarrhea, so they will affect your gut metabolism. So basically remember what they ask you in exam, they ask you these are the add-on drugs, so they are contraindicated in those patients, those who have inflammatory bowel disease, they are contraindicated in IBD. SGLT2 inhibitor, so what are the side effect of these drugs? So they can lead to UTI. ये क्वेश्चन पिछले 2 बार से आ रहा है, अभी भी दोबारा पूछ सकते हैं. They can lead to cystitis. Then remember they can lead to a condition called euglycemic ketoacidosis. This is expected question. Euglycemic ketoacidosis. And what else they can cause? There is some risk of I can say pathological fracture with these drugs on long-term basis. Okay, this is important, so I am writing one more. It can lead to Fournier's gangrene. It can lead to Fournier's gangrene as well. ये gangrene भी करा सकता है. Okay, now we have GLP analog and DPP-4 inhibitor, so they will have similar side effects, similar profile. So they can lead to pancreatitis. They can cause pancreatitis, and these drugs, remember, there is some risk of causing medullary thyroid carcinoma in rat. So they can cause MTC. Then we have tirzepatide, that is your Mounjaro. Okay, acarbose, pramlintide, insulin. These are those drugs which we can use in both type 1 and type 2 diabetes. You can use in both type. These are the drugs. So they ask you which drugs are used in both type 1 and type 2. Metformin should be stopped when creatinine is more than 1.5 in males, more than 1.4 in females. So you can see this is like many celebrities, they reduce a lot of weight because of Ozempic. Ozempic is your semaglutide. So you can see they will have a typical classical appearance. There is like a hatchiness in the face. Gaal pe chak gaye hain bilkul. So this is like a V-shaped necking of face. We call this Ozempic face. So every is having the same side effect. Isko bolte hain semaglutide face or Ozempic face. Okay, now let's talk about some MCQs. So which drug prevents CKD heart failure? Answer is SGLT2 inhibitor. Obesity में क्या दोगे? So what is preferred in obesity? We can use SEMA, we can use liraglutide, or nothing is available, we can use metformin. So these are preferred in obese patient. Post-penile spike के लिए क्या दोगे? acarbose देंगे. We will use acarbose or alpha glucosidase inhibitor. Resting tremor, Parkinson, which drugs we prefer? Remember, bromocriptine we can use because it is effective in both Parkinson as well as diabetes. TIA का patient, what you will use? Thiazolidinedione. So now see, this is about question based on benefit of a drug. Increase creatinine, CKD, then what you will give? Suppose to prevent CKD we are using SGLT2 inhibitor, लेकिन अगर CKD already हो गई है, in that case what we prefer? We prefer to use linagliptin. Now we prefer to use linagliptin. Done. Okay, now coming to bloating. Bloating हो रही है. What drug will use? So bloating can occur because of many drugs. So especially what I will say, acarbose. Side effect of a drug: profound hypoglycemia, sulfonylureas. Ketone bodies, euglycemic ketoacidosis किससे हो रहा था? SGLT2 inhibitor. Bladder cancer risk, from which bladder cancer? Thiazolidinedione. Thiazolidinedione. Pancreatitis किससे होगा? Pancreatitis can occur. Pancreatitis will occur because of GLP analog and DPP4 inhibitor. Fournier's gangrene, again it will be because of SGLT2 inhibitor. So these are questions which they ask on side effect of a drug. Done. So just try to understand this thing. Now they ask you question on complication of diabetes, especially in the complication they are asking you mainly question on DK and coma. So they ask you DK. सबसे पहले DK में क्या दोगे? What we use? First of all, what we use? We give IV fluid, and IV fluid of choice will be normal saline. After this, what we are using? We are using insulin. Then what we choose? We choose insulin. And after insulin, understand what we give? We give IV fluid, then we continue IV fluid and insulin. We continue both. Okay, insulin how we give? We give it as 0.1 mg per kg. IV stat. Suppose my weight is 80 kg, so you have to give me 8 units. Then what we do? After this, what I am doing? We continue both IV fluid and insulin. Then what you should do? Understand this thing. Insulin will drag potassium from blood. I can say it will send potassium back to cells. So what we'll do? We have to supplement the potassium. So we give KCl. Then when RBS is less than 250, then we are using dextrose. Next morning you will repeat ABG sample. If still acidosis, then we can use soda bicarb. But remember, soda bicarb is optional. It is not for every patient. तो यहाँ से क्वेश्चन बार बार आ रहा है. It's a burning topic, hot topic which they ask in exam about treatment of DK and coma. Very very important. DK and coma. Okay, now these are the changes which we can see in diabetes as a dermatopathy. We call them diabetes dermatopathy. Means these are skin changes. So इसको क्या बोलते हैं? We call this diabetic dermopathy. These are skin changes that we see in diabetics. Okay, now these are those infections which are unique in diabetics. These are those infections which are uniquely present in diabetes. तो मीन्स अगर ये इन्फेक्शन है तो पेशेंट ज़्यादातर कैसा होगा, तो मोर लाइकली चांस पेशेंट विल बी डायबिटिक. डन, it will be diabetic. Okay, now they ask you question on different type of tumor. So let's understand this tumor. Gastrinoma. Gastrinoma means we also call this Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. So it will be in the triangle of Passaro. In the triangle of Passaro. So gastrinoma means more gastrin. More gastrin means more peptic ulcer. So patient को क्या होगा? Patient will have refractory peptic ulcer. There will be refractory peptic ulcer. VIPoma, understand. VIPoma, we also call this VADA syndrome. So what is this VADA? Now understand this thing. VADA means patient will have watery diarrhea. Watery diarrhea. There will be hypokalemia. Hypokalemia and achlorhydria. Watery diarrhea, hypokalemia, achlorhydria. So now understand this thing, we call this VIPoma. So VIPoma is something where you will see watery diarrhea. Now coming to watery diarrhea और कहाँ पढ़ा था हमने, cholera में. So we also call this pancreatic cholera. इसको क्या बोलते हैं? Pancreatic cholera. Glucagonoma. Glucagonoma, understand this thing. Here patient will have more glucagon level. More glucagon level means patient will develop diabetes. There will be diabetes, and diabetes, along with diabetes you can see a skin rash. We call this necrolytic erythema migrans. Necrolytic erythema migrans. So this will be a rash that we see. Okay, now coming to insulinoma. Insulinoma means more insulin. So more insulin. Insulinoma कैसे आएगा? It will present with hypoglycemia. There will be hypoglycemia. So now understand this thing. Insulinoma patient, how it will present? It will have a Whipple's triad. So patient will have Whipple's triad. So what is Whipple's triad? Understand this thing. Whipple's triad means patient will have low glucose. So patient will have low glucose. Then you can notice patient will have symptom of low glucose. Hypoglycemic symptom, okay, and these symptom will resolve when you give glucose. So symptom will resolve when you give glucose. We call it Whipple's triad. Whipple disease, it is due to Trophirema whipplei. Trophirema whipplei. Trophirema whipplei means it is like a parasite. It's a bacteria which comes under actinomycetes. And Whipple's procedure, it is name of a surgery for pancreatic cancer. Pancreatic cancer की surgery करा मैं. Okay, now look at this. Let's talk about this. Is called your Pemberton sign. So you can see whenever patient will raise arm, there is flushing of face. इसको बोलते हैं Pemberton sign. Now look at this. You can see increase uptake. You can see decrease uptake. So this is increase uptake. So increase uptake where we can see in Graves' disease. You can see bilateral increase. In toxi-maternal goiter, you can see here, you can see increase uptake, but this increase will be irregular. Irregular means कहीं पर ज़्यादा होगा, कहीं पर कम होगा. And when you see centralized increase, increase in the center. When you see a centralized increase, it is toxic adenoma. So this is about your question which they ask on radioactive iodine uptake scan. We call this RIO scan. Radioactive iodine uptake scan. Okay. Now what they ask you question on like how we see a patient. So you can notice in thyroid dysfunction, you can notice this is a side effect which we see with different type of anti-thyroid drugs, especially carbimazole, metamizole. We call this aplasia cutis. इसको क्या बोलते हैं? We call this aplasia cutis. So it occur due to carbimazole, metamizole. These are signs of grave disease. So you can see this is like grave patient. They can develop, I can say, swelling in the legs. So what we call this? You can see we call this dermopathy. You can see here ophthalmopathy, changes in the eyes, and some people they can develop clubbing, nail clubbing. So इसको बोलते हैं acropathy or thyroid acropathy. Understand? This is what we call edema in the legs, so we call this pre-tibial mixed edema. Pre-tibial mixed edema. Normal hypothyroid will have generalized mixed edema, but in hyper you will see pre-tibial mixed edema. Okay, now understand. This is typical hypothyroid face. You can see a typical hypothyroid face. You can see a tight skin, but you can see these xanthomas due to dyslipidemia. You can see skin will be tight. Okay, refractory hypothyroidism, when you will call refractory, when there is no improvement. When there is no improvement after taking 200 microgram levothyroxine daily. When daily you are taking 200 microgram and no improvement, we call this refractory. Okay, now coming to subclinical. Subclinical hypothyroidism means here in subclinical T3, T4 will be normal and TSH will be slightly increased. Sick euthyroid, here everything will be normal, but sometimes you can see there is more peripheral conversion, so T3 can be low. T3 sometimes can decrease, rest everything will be normal. When thyroid storm it occurs during thyroid surgery, T3, T4 they come into circulation, so it can increase your sympathetic drive, so heart rate, BP can increase, and there is more calogenesis, so temperature will increase. They ask you how we prevent this. So for prevention, what we use Lugol solution, or we call this potassium iodide. And in treatment, suppose if it is not after you have tried this also but no improvement coming, then what we can use PTU by NG tube. So in thyroid storm, remember, for prevention we use Lugol solution, and drug of choice if it is occurring, then we use propyl thiouracil. Most common complication after thyroid surgery will be bleeding. Okay, now we have different type of thyroiditis. So we have Hashimoto's, that is most common type. Most common, actually it's most common cause of hypothyroidism, CTLA4 gene, HLA, DR3, DR4. Then subclinical. So we have subclinical, or I can say subacute, but better term is subacute. You can see it occur post-viral. It is your decurvan. Then renal, it is nothing. There is a fibrosed gland, so it can present with stridor dysphagia. Okay, then they ask you question on hepatology. Okay, we'll take a short break. So come back in 15 minutes. We'll resume the session after 15 minutes. Okay guys, so we have finished ABG part and ECG, important ECG part, and some part of endocrinology and rheumatology. So you can watch those things later on. Now let's continue with the another important thing which they ask on liver. So basically in liver what they ask you a question on how to approach a question. In the MCQ if you see AST-ALT ratio, AST-ALT value, suppose if AST value is more than ALT, अगर AST की वैल्यू ALT से ज़्यादा है then more likely this is due to alcohol, and when ALT value is more than AST then this liver damage is done because of viral. Simple. So what is important for this? What we calculate AST-ALT ratio. So AST-ALT ratio if it is more than 2:1, this is suggestive of alcohol induced liver damage. तो normal value दोनों की 40 तक होती है, up to 40 is normal. When this value is more than 3:1, this is definitive of alcohol, and when value is more than 5:1, तो mark कसम it is due to alcohol. Very very important. So what is important? AST-ALT ratio. Then understand they ask you for hepatic synthetic function. We have marker like PT-INR. So PT-INR is marker for hepatic synthetic function. CLD का मार्कर क्या होगा? CLD का मार्कर होगा albumin. Albumin is negative acute phase reactant and albumin की वैल्यू कम हो जाएगी. So understand this thing. This PT will measure your extrinsic pathway. CLD with hypergammaglobulinemia. So normally understand this thing. CLD के साथ क्या होगा? Immunoglobulins are less, gamma globulins are less. But in autoimmune disease causing CLD, then you will see CLD with more immunoglobulin, like autoimmune disease like autoimmune hepatitis, primary biliary cholangitis. So remember CLD के साथ hypergammaglobulinemia कब होगा? जब कोई autoimmune disease CLD में convert होगी. Okay, now look at this. They ask you question on alcoholic fatty liver disease, alcoholic hepatitis, or alcoholic cirrhosis. So alcoholic fatty liver we call this AFLD. क्या symptom होंगे? There will be no symptom. Alcohol cirrhosis, understand, here you will see right upper quadrant pain, patient will have nausea, patient will have vomiting. So understand this thing, alcohol cirrhosis, it was first coined by Leynac, so इसको हम बोलते हैं Leynac cirrhosis, and it is a micronodular cirrhosis. Now what they ask you in exam, आपसे पेपर में क्या पूछते हैं? How you manage alcohol hepatitis patient? So alcohol hepatitis को कैसे manage करोगे? So understand this thing. So first thing is like we stop alcohol, we will give IV fluid to patient plus multivitamin. Then we can use a drug called pentoxifylline. Then we calculate a score. आपको एक score calculate करना है. The score is called as Madris score, or we call this Madris discriminant function. So Madris score की value, if this Madris score value is more than 32, then what we give? Then we give steroid. So drug of choice in alcohol hepatitis will be steroid. Simple. Okay, now understand. They ask you few question like CAGE questionnaire. CAGE का मतलब क्या होता है? Have you ever cut down your alcohol intake? C for cut down. A for do you feel annoyed of being an alcoholic? G for guilty, तो कभी guilt लगता है, and E for eye opening drink. So do you need eye opening drink? So these are MCQ what they ask you in exam. They ask you MCQ where? Yes, PDF will be shared, Vishwajit, don't worry. So these are called CAGE questionnaire. So they ask you question on alcohol. Alcohol से exam में बार बार question आता है. So topic we are discussing is alcohol. So drug of choice for alcohol addiction. For alcohol addiction, what we use? We use disulfiram. Now look at this. For alcohol withdrawal. Withdrawal means patient को withdrawal symptom आ रहे हैं, वो सो नहीं पा रहा है, tremors हो रहे हैं, तो उसको आपको शांत करना जरूरी है. शांत करने के लिए क्या दोगे? Benzodiazepines. We use benzodiazepines. And remember which benzodiazepine we use? We use chlordiazepoxide. बट मोस्ट बेंजोडाइजेपाइन इंक्लूडिंग क्लोरडाइजेपोक्साइड दे आर हेपाटोटॉक्सिक. लेकिन अगर पेशेंट को लीवर डैमेज है, इफ लीवर डैमेज इज देयर, AST ALT बढ़े हुए हैं, then we will not give this. So if liver damage is present, in that case what we use lorazepam or oxazepam. तो ये lorazepam भी एग्जाम में एज अ क्लिनिकल केस आया हुआ है. दिस केम एज अ क्वेश्चन लाइक पेशेंट्स हैविंग लिवर डैमेज. ओके, नाउ अंडरस्टैंड दिस थिंग. दिस इज अबाउट योर मैड्रिस डिस्क्रिमिनेंट फैक्टर. अगर मैड्रिस की वैल्यू 32 से ज़्यादा है, मैड्रिस डिस्क्रिमिनेंट फंक्शन, then what we give prednisolone. Okay, now try to understand. They ask you NAFLD. NAFLD के आजकल कुछ नए नए नाम आ गए हैं. So we call this NAFLD, and NAFLD can convert into NASH, non-alcoholic steatohepatitis. So we also call this आजकल, what we rename this, we call this MASH, metabolic associated steatohepatitis. So they ask you NAFLD NASH, how you will manage. कैसे आप manage करते हो? So we can use vitamin E. We can use vitamin E, we can use coffee, so caffeine is protective. Then we can use omega-3 fatty acid. We can use omega-3 fatty acid. And last option, we have a new drug. This new drug will be saroglitazar. Saroglitazar. Very, very important. So it is non-alcoholic fatty liver disease. Okay, now coming to viral hepatitis. So they ask you question on family, means किस family members हैं. So just remember, it is picornavirus, hepadnavirus, flavivirus, delta virus, हेपेवायरस. हेपे की सब फैमिली होती है कैल्सीवायरस. तो जस्ट रिमेंबर द निमोनिक. पीएच फुल डेंजरस है, पीएच फुल डेंजरस है. Now what they ask you, nucleic acid. So only B, सिर्फ B में क्या होगा? DNA होगा. Only B is having DNA. बाकी सब में क्या होगा? You will have RNA, RNA, RNA. So only B is having DNA. कैसे याद रखोगे? Remember mnemonic BD, BD जलाई ले, BD, simple. Now coming to route, A and E. A and E, they spread by fecal-oral route. Fecal-oral route. BCD, they will spread via blood. Envelope, A and E, they are unenveloped. Now coming to BCD. So BCD, these are enveloped. अब देखो acute कौन सा कराएगा? C को छोड़ के all can cause acute illness. Now coming to chronicity and cancer. Chronicity cancer, that's the feature of only B and C. So chronicity cancer किससे होगा? B और C से होगा. But very very important thing which they ask you in exam is question based on hepatitis B marker. तो पहले इस marker को समझो. So we have different markers, and these markers you can remember by mnemonic SCE, CES. SCE means HBS antigen, HBC antigen, HBE antigen. So first three will be sequence of antigen. So S antigen, if it is positive, it means virus की entry हो गई. It means virus have entered. HBC antigen is not detected. So इससे एक ही क्वेश्चन पूछते हैं, which is not detected. So not detected, so generally not asked in MCQ. So MCQ में पूछते भी नहीं. HBE एंटीजन अगर पॉजिटिव है, इट मीन्स द वायरस जो एंटर किया आपके बॉडी में वो डिवाइड कर रहा है, दैट इज रेप्लिकेटिंग, दैट इज डिवाइडिंग. इट मीन्स इट इज टर्निंग इनटू मोर एंड मोर इन्फेक्टिव. सो इट्स अ मार्कर ऑफ इन्फेक्टिविटी. देन वी हैव एंटीबॉडीज. सो लेट्स सी द एंटीबॉडीज. सो वी हैव एंटी-HBC. एंटी-HBC के दो टाइप होंगे. सो वी हैव IgM एंड वी हैव IgG. सो इफ IgM इज पॉजिटिव, it means it is acute illness. If IgG is positive, this means chronic illness, simple. Then we have antibodies against the envelope antigen, इसको बोलते हैं anti-HBE. So, अगर ये पॉजिटिव आ रहा है, इसका मतलब अब वो इन्फेक्टिव नहीं, अब वो डिवाइड नहीं कर रहा है. So that means it's no longer dividing, so it is non-infective. and finally if you develop antibodies against the surface antigen, it means we have cured the disease. आपने disease को ठीक कर लिया. Now in exam what they give you 3-4 तीन चार चीजें दे देंगे and they'll ask you to make a diagnosis. So let's see what they will give you. Suppose let me start with the first one. So suppose अगर मैं आपको लिखूँ यहाँ पर surface antigen is positive, envelope antigen is positive, IgM is positive, what is the diagnosis? बताओ. एंट्री हो गई, डिवाइड कर रहा है, इन्फेक्टिव है, acute है, so we call this acute hepatitis B. Acute hepatitis B. Suppose if I say surface antigen is positive, HB antigen नहीं दिया positive, IgG is given positive, तो इसको क्या बोलोगे? IgG is positive means chronic है, so it is chronic. Okay, now see hepatitis B. अब here you can notice here HBE is positive, इसका मतलब ये डिवाइड कर रहा है, so we call this acute infective type of hepatitis, acute infective hepatitis B. But chronic इसमें आपको पता नहीं, if nothing is given then we cannot comment on infectivity. Suppose अगर मैं ऐसे लिख दूं HBs antigen positive, IgM is positive, HBE antigen की जगह if I say anti-HB is positive, now what you will call this? You will call this acute non-infective hepatitis. Non-infective hepatitis B, because it is no longer dividing. Suppose if you see only this is positive, अगर सिर्फ ये positive आ गया, then what do we call this? Antibodies against. अब इसको आप लोग बोल रहे हो क्योर, नो इट इज नॉट क्योर. क्योर से पहले क्या चाहिए? एंट्री. एंट्री तो हो नहीं, तो उसको हम बोलते हैं वैक्सीनेटेड. दिस इज वैक्सीनेटेड. एंड सपोज इफ आई राइट लाइक दिस, दिस इज व्हाट वी कॉल दिस क्योर्ड. एंट्री हुई फिर ठीक हो गया, क्योर्ड. नाउ सी IgM इज सो फास्ट, IgM इतना फास्ट होता है, सो इट कम पॉजिटिव. सिर्फ IgM अगर पॉजिटिव है, so IgM turn positive before surface antigen to turn positive. So this phase is called window period. इस phase को क्या बोलते हैं? We call this window period. Very very important. So this is about different types of marker which they ask in exam. Okay, now try to understand this thing. They ask you a question like how we summarize these different type of hepatitis. तो HbA के लिए कैसे आप diagnose करोगे? Hepatitis A is acute, we check IgM anti-HAV. Hepatitis B के लिए क्या कराओगे? We will do HBs antigen. और अगर ये पॉजिटिव आया, तो बिफोर स्टार्टिंग ट्रीटमेंट व्हाट वी नीड HBV DNA कॉपीज. इसको हम वायरल लोड भी बोलते हैं. हेपेटाइटिस सी के लिए क्या कराते हैं? एंटी-HCV. फॉर डी व्हाट वी डू? डी इज एक्यूट, तो IgM anti-HDV. एंड ई भी एक्यूट होगा तो IgM anti-HEV. सो दीज आर द डायग्नोस्टिक मेथड. अब इसको देखो, ए और ई एक्यूट होता है, तो इन एक्यूट व्हाट वी गिव? इन एक्यूट वी गिव IV फ्लूइड प्लस मल्टीविटामिन, मींस यू हैव टू गिव डेक्स्ट्रोस. IV फ्लूइड, मल्टीविटामिन, अच्छी डाइट दो उसको. बी में भी क्या होगा? इफ बी इट इज एक्यूट, so B can be acute or B can be chronic. So understand this thing, B अगर acute है, then we give same, we give IV fluid plus multivitamin. But in case of chronic, we start a drug, and which drug we start? We start entecavir or tenofovir. Entecavir or any one of this, not both. Okay, coming to C. So C is always chronic. So in C what we use? In C we use a drug. This drug is called sofosbuvir. Sofosbuvir plus daclatasvir or velapatsvir. Daclatasvir or velapatsvir. Now coming to hepatitis D. In hepatitis D, what we use? We use interferons plus we have to treat hepatitis B because D किसके साथ होता है? B के साथ होता है. So this is the summary of treatment of different type of hepatitis which you have to remember before your exam. Very very important. But exam में generally question किससे पूछते हैं? ये markers से जो हमने पढ़े अभी. Very very important these markers. Okay, now try to understand. They ask you what are extrahepatic manifestation. तो B में क्या होगा? PAN, C में lichen planus and mixed cryoglobulinemia. So this also question they ask in exam. So these are some of the extrahepatic manifestation which they ask in exam. Okay, now coming to whenever you see a patient, cirrhosis can occur after hepatitis. So you can notice like they can develop gynecomastia. There can be Palmer erythema. There can be Palmer erythema. And patient can develop this spider angioma. There will be spider angioma. So ascites occur because of increase in splanchnic pressure. And they ask you question in exam like how we approach ascites, we calculate SAG. So याद रखना in CLD what we get high SAG and low protein ascites. In CLD you will get high SAG and low protein ascites. Look at this, SAG value is more and protein value is less. It is seen in CLD or cirrhosis, high SAG, low protein. Okay, puddle sign when fluid is more than 100 ml, shift in dullness more than 500 ml and fluid thrill when it is more than 1000 ml. Now they ask you treatment of ascites. So in ascites what we use? In ascites first what we use furosemide, and spironolactone combination. Furosemide and spironolactone combination. So we start furosemide with 20 mg and we can give this up to 160 mg. Spironolactone we start with 50 mg and we can give this up to 400 mg in a day. Suppose there is no improvement with this maximal dose. कितना है maximal dose? 160 mg furosemide, 400 mg of spironolactone. This ascites is called refractory ascites. So they ask you question, what is refractory ascites? So refractory ascites means ऐसी ascites which is not responding to total salt restriction plus maximal tolerable dose like furosemide 160 mg and spironolactone 400 mg. So in refractory ascites what you will do? You will do LVP. LVP का मतलब होता है large volume paracentesis. और अगर पेशेंट का एल्बुमिन कम है तो उसको एल्बुमिन में चढ़ाओगे, प्लस वी हैव टू गिव एल्बुमिन. सो दिस इज अबाउट योर रिफ्रैक्टरी ascites. Okay, now they ask you hepatic encephalopathy. In hepatic encephalopathy, the most common toxin will be ammonia. So what we diagnose, how we diagnose, we do serum ammonia level. Then we have a West Haven grading. इसको बोलते हैं West Haven grading system. West Haven grading system. And in West Haven grading, understand, we grade cirrhosis. So they ask you most common in the earliest symptom. Earliest symptom will be decrease attention span and altered sleep cycle. ये क्वेश्चन पूछते हैं एग्जाम में. So in grade 2 patient can develop flapping tremors. लास्ट में क्या हो जाता है? कॉमा हो जाता है. So these are called West Haven gradings. So encephalopathy का first sign क्या होगा? Decrease attention span and sleep cycle. Now try to understand this thing. They ask you florid duct lesion, loss of ductal canal of hearing, ductopenia. These are feature where we see in a patient of PBC, and this is what we see pearls on string appearance. So in ERCP or MRCP you will find beaded appearance or pearls on string appearance. It is seen in a patient of PSC, primary sclerosing cholangitis. Okay, Wilson disease they ask you in exam. In Wilson disease they ask you like what you will see. तो liver में क्या होगा? तो liver में patient can develop CLD. In eyes there can be KF ring and a type of cataract. इसको हम बोलते हैं sunflower cataract. Then there can be dysarthria, dystonia. There can be spontaneous abortion. Not that important. Nails में देखो नाखून का जो part होता है, this part is called lunula. ये नीला पड़ जाता है. We call this lunula ceruleae. Then there can be face involvement. You can see there is an empty smile in the face. इसको बोलते हैं vacuous smile. But very important in CNS, they ask you like patient can develop like deposition of copper in your basal ganglia, तो patient को क्या होगा, secondary Parkinson disease. और इस Parkinson disease में जब आप MRI कराओगे, you will find face of panda sign. You will get face of panda sign in Parkinson disease. Okay, now understand. This is your KF ring, which you can see. This ring, it's the insulate lamp examination. Then this is your sunflower cataract. This is vacuous smile, and you can notice here this bluish discoloration of nail. इसको बोलते हैं lunula cerulea. Then patient can develop secondary Parkinson. Okay, they ask you what is initial test. So first test, or I can say for screening, what we do ceruloplasmin. स्क्रीनिंग के लिए आप ये भी कर सकते हो, यूरिनरी कॉपर भी कर सकते हो, बट बेस्ट फॉर स्क्रीनिंग विल बी सर्लोप्लास्मिन. इन स्लिट लैम्प व्हाट यू विल फाइंड केएफ रिंग, स्लिट लैम्प केएफ रिंग. बट व्हाट इज इन्वेस्टिगेशन ऑफ चॉइस? इन्वेस्टिगेशन ऑफ चॉइस विल बी लीवर बायोप्सी. सो दीज आर क्वेश्चन बेस्ड ऑन डायग्नोसिस ऑफ विल्सन डिसीज. ओके, नाउ दे आस्क यू क्वेश्चन ऑन गिस्ट. तो व्हाट इज गिस्ट? गैस्ट्रो इंटेस्टाइनल स्ट्रोमल ट्यूमर. सो गिस्ट पे पिछले 2 साल से क्वेश्चन बार आ रहे हैं. You can see like spindle cells, epithelioid cells, and they ask you how we are going to manage GIST. So in GIST treatment, what we use imatinib. And what is imatinib? It is tyrosine kinase inhibitor. Imatinib we also use in CML patient. इसको और कहाँ देते हैं? CML में देते हैं. Then they ask you why GIST occur. It is basically a tumor. Most common site of GIST will be stomach. Most common site will be stomach. Okay, now understand. Hemochromatosis से क्वेश्चन क्या पूछते हैं? They ask you what is the name of gene. So it is HFE gene. It occurs because of HFE gene. And there is iron accumulation. So there is iron accumulation in different organs. So there is bronzing of skin. Iron accumulation in pancreas can lead to decreased insulin release. So इसको हम बोलते हैं bronze diabetes. It can be acquired कैसे हो सकती है? Because of excessive blood transfusion or excessive iron supplementation. Patient suppose iron के supplement ले रहा है, तो एक बार क्वेश्चन आता like patient taking iron supplementation even though hemoglobin is 14 from past 6 months. hemoglobin जब normal है तो iron क्यों ले रहे हो? And that can lead to hemochromatosis. So you can see the color change. We call this bronzing of skin. So they ask you what is the treatment of choice. So we have to remove the excess blood, and that is how we do. It is phlebotomy. Okay, so these are different score we have. So MELD score का मतलब होता है मॉडल फॉर एंड स्टेज लिवर डिसीज. MELD स्कोर क्वेश्चन कई बार आ चुका है. कंपोनेंट आर CBI, क्रेटिनिन बिलिरुबिन INR. सेकंड इज पीडियाट्रिक वर्जन PELD स्कोर. बच्चों को क्या बोलते हैं? निब्बा बोलते हैं. निब्बा मीन्स न्यूट्रिशन स्टेटस, INR, एल्बुमिन, एज, bilirubin. So NIBA. Naser index. So Naser index, it is done for liver transplant in Wilson. So component are SBI, SGOT, bilirubin INR. MAD discriminant score. ये मैंने अभी आपको बताया था. It is for alcohol hepatitis, and when this value comes more than 32, तो हम क्या start करेंगे? Then we start steroid. Then we have child pug. Child pug is for grading of cirrhosis. तो child pug में क्या आएगा? In child pug what we have? In child pug we have ABCDE. In child pug we have ABCD. So ABCD means A for albumin, B for bilirubin. Yes, PDF will be shared. C for A for albumin, B for bilirubin. Now understand this thing. C for clotting. Clotting means coagulation cascade, means PTINR. D for distension. Distension means ascites. And E for encephalopathy. E for encephalopathy. So these are component of child pug. And last is BARD score. So BARD score, just remember the name. So BARD score you have to remember for NAFLD, non-alcoholic fatty liver disease. Then Okay, now coming to hematology, what they ask you question on how to approach a question of anemia, कैसे आपको approach करना है. Sometimes they ask you question on multiple myeloma. So multiple myeloma से हर बार एक question आता है. So just try to understand this thing. In multiple myeloma, they ask you how we make a diagnosis. So whenever we have clonal plasma cells more than 10%, or you can see there will be biopsy proven plasmacytoma, plus what we need crab feature. Now what is this crab feature? C for calcium increase, R for renal involvement, A for anemia, B for bony lytic lesion. So this crab feature are also called as MDI. MDI का मतलब होता है myeloma defining illness. So these are myeloma defining illness. Crab feature. Okay, now understand. They ask you in cardiology 3 common symptoms: angina means chest pain, shortness of breath, palpitation. So these are 3 common symptoms in cardiology. Now when they ask you angina, we have obstructive angina, we have vasospastic angina, also called as prinzmetal angina. We also call this as prinzmetal angina. Vasospastic और क्या बोलते हैं, prinzmetal angina. Then NYHA, understand this thing, it is called NYHA, New York Heart Association. It is a classification for dyspnea in heart disease. So class 1 means no limitation, class 2 means slight, class 3 means marked, class 4 means symptom at rest. लेकिन dyspnea अगर lung disease के लिए होगा, उसके लिए what we have modified medical research council scale, MMRC scale. It is dyspnea for lung disease. So grade 1 means 1 look like hill, so dyspnea and walking uphill. 2 means 2 people. 2 means comparison of 2 people. 2 people, both are suppose 50 years, one is walking slower than person belonging to same age. Comparison. 2 means comparison, walking slower than contemporaries of same age. 3 means 100 को अगर आप देखोगे, 100 means 1 2 3. 100 means 1 2 3 words. Dyspnea on walking 100 meter. 4 means floor. Floor पे पड़ा हुआ है. To disconnect, to leave the house. So this is about your MMRC. Okay, now then what they ask you irregular pulse. So we have 2 type of irregular pulse, regularly irregular and irregularly irregular. So regularly irregular, where you will see. So regularly irregular you will see where? In second degree AV block. Which type? Constant or variable वाली? Constant type. Constant type. And what we call this? इसको क्या बोलते हैं? Mobitz 2. Then they ask you where you will see irregularly. In fact, irregular, where also you will see Gemini rhythm. And Gemini rhythm means like bi-Gemini, tri-Gemini. It is seen where? It is seen in digoxin toxicity. Irregular, it is a feature of atrial fibrillation and VPC. VPC means ventricular premature contraction. So बार-बार आपसे क्वेश्चन पूछते हैं atrial fibrillation. Okay, now coming to apex pulse deficit means audible S1 minus palpable pulse rate. You have to see the difference. So एक हाथ से आपको क्या करना है, हार्ट साउंड को फील करना है, स्टेथोस्कोप को यहाँ लगाना है, दूसरे से आपको क्या करना है, पल्स रेट फील करनी है. So normal you will see the difference. तो normal apex pulse deficit it is 0. Means normally you get both at same time. Means you will hear and feel both at same time. But suppose when you are auscultating, then heart rate is coming around 70, and on palpation it's coming around, let's say 60. Difference आ गया. So if APD value, understand, it is less than 10 beats per minute, it is due to VPC, and it is more than 10 beats per minute, it is due to AF. So ये last year clinical case आया था AF का, apex pulse deficit more than 10 beats, atrial fibrillation. Done. Okay, radiofemoral delay, where you will find this in aortic arch problem. तो बार-बार क्वेश्चन आता है, they ask you question on Takayasu. So wherever we have problem in aorta, you will find radiofemoral delay. Now look at this, we have different type of pulse. So this is called first pulse, that is called anacrotic pulse. Anacrotic pulse means it is also called as pulsus parvus et tardus. It is also called as pulsus parvus et tardus. Pulsus parvus et tardus, and where we see it is seen in a patient of AS. Second type of pulse is called bispherians. Bispherians means you will see two peaks. You will see two peaks, and both peaks are coming in systole. दो peak आ रही, दोनों systole में आ रही. So bispherians you will see where in a patient with severe AR and AS together, only AR and a patient of HOCM. Third pulse is called dicrotic pulse. अब देखो यहाँ पर भी दो peak हैं, but first peak you are seeing in systole and second peak you are seeing in diastole. So this dicrotic pulse, it is seen in a patient of DCMP, and it is seen in typhoid fever, and typhoid sometimes can convert into sepsis. So it is also seen in sepsis. It is also seen in sepsis. Fourth type of pulse. Fourth type of pulse is called as pulsus alternans. This is pulsus alternans, and it is seen in any patient those who are having LVF, left ventricular failure. So alternans में L आ रहा है, left ventricular failure. Then we have bigeminy, trigeminy. This is number 5. We call this Gemini rhythm. So it is seen due to digoxin toxicity. Sixth pulse, we call this Corrigan pulse. Corrigan, or what we call this collapsing pulse. इसको और क्या बोलते हैं? We call this water hammer pulse, and this is seen in a patient of AR. So in single line you can see all the pulse I have covered. A very important slide of pulse, very important. Let's talk about JVP. So in JVP we use two scale method. So A wave is because of atrial depolarization, or I can say atrial contraction. Which atria? In JVP we always talk about right side, right atria. C wave. C is due to contraction of ventricles. Contraction of ventricle means which ventricles? It will be your right ventricle. Contraction of ventricles, that means it will be due to contraction of right ventricles. Now coming to V wave. When you can get V wave? V wave is because of vena cava filling. So V is because of vena cava filling. So V, vena cava filling. Now what we have? We have X descent. We have X descent. It is due to atrial relaxation. Atrial relaxation. And then what we have? We have Y descent. So Y descent is seen because of emptying of RA into RV. You will see it because of emptying of RA into RV. So these are the questions which they ask on JVP. Simple question, physiology question. Now sometimes they ask you a medicine question. You can see absent A wave. So when A wave is absent, it is a classical feature that we see in patient of AF. Very important. Now let's see large A wave, where you can see whenever right atria is contracting against some, I can say, stenotic wall, against some resistance. So you can see in pulmonary hypertension, tricuspid stenosis, you will see large A wave. So this A wave will be large. Sometimes you can see this A wave is very large. When it is very large, what we call this cannon A wave. Now understand, when we see cannon A wave, it is seen in VT, VPC, PAC and complete heart block. So here you will see cannon A wave. Okay, next what we have? We have prominent X. It is seen in cardiac tamponade. Cardiac tamponade. And what we have? We have a prominent Y. Where we see prominent Y? So prominent Y you will see where? In chronic constructive pericarditis. Clear? So prominent X and prominent Y. It is seen in chronic constructive pericarditis. So this is something which you have to remember. Okay, now try to understand this thing. Absent X CV abnormality. The CV abnormality इसको बोलते हैं Lenz CZ sign. ये last year NEET PG में आया था. It is seen where? In TR. tricuspid regurgitation. So these are all the MCQs which I have discussed about JVP. Very very important. Okay, now they ask you question, pulsus paradox कहाँ मिलता है? So pulsus paradox is seen in many conditions, but in exam what they ask you, COPD, asthma and cardiac tamponade. Very very important. It is pulsus paradoxus. Then they ask you where you will find Kussmaul sign. So Kussmaul sign you will find in chronic constrictive pericarditis. ये last year आया था आपके exam, in your exam. Chronic constrictive pericarditis. Okay, now coming to heart sound. So this they ask in exam. The question बार बार पूछते हैं exam में, so based on location of valve. So just remember, all people enjoy Time magazine, right? All people means aortic valve, pulmonary valve. Then we have Erb's area, then we have tricuspid valve and mitral valve. So here यहाँ पर होगा Erb's area. So this will be the Erb's area. तो कभी कभी ये फोटो एग्जाम में आता है, they ask you to locate these valve. So what is the location of each of these valve? Just remember one more area you can see here in first intercostal space. यहाँ पर भी एक area होता है. Here you will find machinery murmur of PDA. This area is called as Gibson's area. और Gibson's area में किसका मर्मर होता है? You will find PDA murmur, patent ductus arteriosus. Okay, so we have S1, S2, we have different type of heart sound. So let's understand this thing. So in S2 you can see some gap is there, we call it splitting. So ASD will have fixed wide split S2. ASD will have fixed. Now see, wide split means in S2 we have two components. So aortic valve will close, then pulmonary will close. So there is a gap between these two. तो इसको बोलते हैं A2 P2. तो normal gap कम होता है, अगर ये gap बढ़ जाता है इसको बोलते हैं wide split. लेकिन अगर उल्टा हो जाए, if it's opposite, like pulmonary closes first, so we call this P2 A2. So what we call this? We call this paradoxical split, and it is called as wide split. So right bundle branch block, pulmonary artery hypertension, pulmonary stenosis, VSD, ASD, you will find wide split. And remember in ASD, what I told you, in सब में क्या होगा? It is variable. It is variable split S2. But in ASD you will see fixed split S2. Fixed split S2. Okay, so again you can see here this is ASD, you can see fixed split S2. Then here you will notice it will be like variable split. Then here you can see reverse split or P2 पहले बंद हो रहा है, तो what we call this reverse split or paradoxical split. S3 and S4 these are best heard where at cardiac apex in left lateral position, and these S3 S4, understand this thing, these are called gallop rhythm and these are seen as a sign of heart failure. So S3 S4 these are sign of heart failure. Ejection click you will see in aortic stenosis, opening snap in mitral stenosis, pericardial knock or pericardial shudder you will see in chronic constrictive pericarditis, and tumor plop sound you will see where tumor plop sound कहाँ होगा? In a patient who is having myxoma. So this is a myxoma, you can see this is a myxoma here, a tumor which is here, and this tumor is affecting this valve. So this valve will be your mitral valve. So these are leaflet of mitral valves. So these are the leaflet, you can see these are the leaflets of mitral valve. And in next slide you can notice here this myxoma is just invading through mitral valve. This effect is called ball valve effect, means tumor whenever it's entering mitral valve it will produce a sound. उस sound को बोलते हैं tumor plop sound. Okay, now they ask you murmur based on their timing, like systolic murmur. So we have early systolic, mid systolic, late systolic. So early you will see in acute MR and VSD. Late you will find where in AS and PS. Mid you will find in ASPS. Late you will find in MVP, mitral valve prolapse. Diastolic you will find early in ARPR. Late you will find cardiocomb murmur, that is a murmur due to mitral valvulitis in patient of rheumatic fever. Then continuous murmur you will find in PDA, in Gibson's area. And remember, murmur mostly we talk about artery murmur. Only venous murmur is your mammary shuffle, that is seen in female breast due to venous engorgement. Okay, chronic MR murmur. Now coming to murmur radiation, MR and TR murmur, it will radiate to axilla. TR murmur radiate to epigastrium and right sternal border. VSD murmur will go to apex. Still murmur, it is mid systolic murmur by starting supine position. All murmurs will decrease on Valsalva standing amyl nitrate except two murmurs. Which two murmurs? Except murmurs of HOCM and MVP. Same thing, all murmurs will increase on leg raise, squatting and hand grip exercise. Exception will be same. It will be HOCM and MVP. HOCM and mitral valve prolapse. So these are the question based on murmurs. So again you can notice here. So this is like a slide, sometimes they ask an exam, like here you can see PDA will have continuous murmur. Named murmur, when they ask you like Carey Combe and Austin Flint, these are the questions. Sometimes they ask you Graham Steele also. So these are questions which they ask on different named murmurs. Okay, now look at this. We have pericardial disease, like acute pericarditis. We call when it is less than 6 weeks, when it occurs in less than 6 weeks. And we call subacute when it is occurring from 6 weeks to 6 months, and chronic more than 6 months. So patient will have a rubbing sound. We call this pericardial friction rub, which is felt when patient is sitting and leaning forward. Now understand, we have two diseases, cardiac tamponade and chronic constrictive pericarditis. And what type of MCQ they ask you in exam? First MCQ is based on heart sound. So here you will see muffled heart sound. Muffled heart sound. There will be raised JVP and there will be hypotension. Hypotension. It is what we call, इसको क्या बोलते हैं? We call this backstride. We call this backstride. Coming to chronic constrictive pericarditis, here patient will present to you with palpitation. There will be palpitation, or sometime there can be chest pain. So pericarditis patient can have angina like chest pain. So this will be the difference based on symptom. Let us talk about ECG. So ECG में क्या मिलेगा? So whenever some fluid is there, then you can see there is low voltage ECG. Low voltage ECG. Here you will find ECG will have ST segment or T wave changes. ST segment T wave changes. Third difference, when they ask you like whenever you are having a patient of cardiac tamponade, you will find classical feature is pulsus paradoxus. And in chronic constrictive pericarditis, you will find Kussmaul sign. Kussmaul sign. Then understand, they ask you like, suppose you are having a patient on cardiac tamponade. When you see a patient of cardiac tamponade, you will notice like these patients in JVP, what they will have? They will have a prominent X. Here you will find a prominent Y. So prominent X, prominent Y. Now understand, coming to treatment. So here what we'll do emergency pericardiocentesis. But in patient who is having chronic constrictive pericarditis, here what we will do an open surgery. So these are the difference between cardiac tamponade and chronic constrictive pericarditis. Okay, look at here, you can notice this is here like money bag appearance, or I can say we call this money bag or Portley bag appearance, and this is chronic constrictive pericarditis. So you will find like in diastolic waveform a sign called square root sign. Square root sign where we will see chronic constrictive pericarditis. Then look at here, this is your a prominent X descent, a prominent X, and this will be a prominent Y. Prominent X, prominent Y. Okay, electrical alternance, we call it swinging Hertz sign, pulsus paradoxus, money bag, E-Watt sign. So these are the signs that we see in a patient of cardiac tamponade. Cardiac tamponade. Broadband sign, square root sign, pericardial friction rub, it is a feature of chronic constrictive pericarditis. Simple. So they ask you this type of question in exam. Okay, now try to understand. They ask you question on different types of antiarrhythmic drugs. So just remember, we have class 1, 2, 3, 4. It's called Vaughan-Williams classification. So remember a mnemonic. Some block potassium channel. Some means sodium channel blocker. Block means beta blocker. Potassium means potassium. Channel means calcium. So some block potassium channel. Then we have a class called class 5, or you can say other class, or we call this miscellaneous class. So here we have DAM. DAM is digoxin, atropine, adenosine, MgSO4. This class 5, here all are the drug of choice, all are IV drugs, and all are used in a particular condition. Like digoxin you will use whenever patient will have atrial fibrillation plus heart failure. Atropine we will use in those patients with bradyarrhythmia. Adenosine is used in patient with PSVT, and MgSO4 you will use in a patient with torsades. So these all are MCQs. Remember Vaughan-Williams classification. Okay, so understand this is like again Vaughan-Williams class 1, 1A, 1B, 1C. So 1A what we have, quinidine procainamide. Procainamide is drug of choice for WPW syndrome. Class 1B is lidocaine. So lidocaine is considered safest drug. It is used in digoxin-induced arrhythmia, but drug of choice will be digibind. Class 1C is flecainide. Flecainide is oral drug. Procainamide is IV drug. Flecainide is oral drug in WPW syndrome. Both these question came. In class 2 we have all beta blocker except sotalol. In class 3 you can see these are like drugs like imidazole, dronedarone, sotalol, ibutilide, dofetilide. Class 4 what we have verapamil, diltiazem. So these are the drugs which we have in Vaughan-Williams classification. Now look at this. Bradyarrhythmia, they ask you what is most common. Most common it will be sinus bradycardia. Most common will be sinus bradycardia. And they ask you which endocrine disorder is associated with. So it is, remember, your hypothyroidism. Hypothyroidism is the one which is associated with AV block. The blocks also we have discussed. Now coming to WPW syndrome. Remember in WPW we have bundle of Kent. Delta waves are there. It is slurry upstroke initial portion of QRS. Then we have long-Levine syndrome where delta wave is absent. QRS will be wide, QRS will be normal. So just remember WPW they ask routinely in exam. In both the case, remember treatment of choice in both. It is radio frequency ablation of aberrant pathway. Radio frequency ablation of aberrant pathway. Okay, now coming to Brugada syndrome. So like it is because of your SCN5A mutation. SCN5A mutation, Brugada syndrome. Patient can have association with right bundle branch block. So just try to understand we have two types of Brugada syndrome. First is called a type 1, we have curved type, curved pattern, saddle back type of pattern. You can say curved pattern where you can see ST segment will descend with an upward convexity. And sometimes you can see like saddle back or biphasic T-wave type of appearance, we call it saddle back pattern. And this patient is always having risk of sudden cardiac death. Sudden cardiac death. So it is seen where in Brugada syndrome. Now coming to endocarditis, what they ask you, single culture positive for certain bacteria. So how many culture we need? We need 3 separate culture. 3 separate culture, each with aerobic and 1 anaerobic. And now what they ask you question how we make a diagnosis. कैसे आप diagnose बनाओगे? So we have Duke's criteria. What we call this? We call this revised Duke's criteria. Revised Duke's criteria. So in this what we need, even single positive culture for one bacteria that can make a diagnosis, that is Coxiella. So single positive culture will be for which bacteria? Coxiella. So what we give penicillin or ceftriaxone plus gentamicin for 2 weeks. If in case of Burkholderia we give trimethoprene sulfamethoxazole or any third cephalosporin or meropenem. Rheumatic fever, they ask you in exam, most common will be arthritis. But if I ask you actual most common will be subclinical carditis. Subclinical carditis in echo. In 2D echo, this will be the actual most common. And chorea will mainly affect your upper and lower limbs. This chorea, you can say it is least common. Chorea is the one which is least common. So you can see bread and butter type of pericarditis and rheumatic fever. You can see like this is caterpillar cells. We call them caterpillar cells or Anichko cells. These are modified macrophage which we see in a patient of rheumatic fever. Then patient will have a hallmark feature. This is like made up of dystrophic calcification. we call them ash of bodies. These are ash of bodies. Okay, now let's understand this thing. What else they ask you in exam? They ask you a question on heart failure. How we make a diagnosis for heart failure? Remember, anti-pro-BNP should be positive. Anti-pro-BNP, and you can see this curly B lines in the X-ray, and you can notice there will be this bat wing pattern. We call this bat wing type of pulmonary edema. Bat wing pattern. Then try to understand this thing. What else they ask you? They ask you question on some important topics which I am summarizing now, and try to understand this thing. Like in exam, they ask you question on these signs. So what do we call this? We call this Chvostek sign. This is your Chvostek sign. When you tap on the cheeks, there will be twitching of eyelid. This is your Trossy sign. Chvostek sign and Trossy sign. So these are two signs which we see because of low calcium, because of hypocalcemia. So these are signs that we see because of hypocalcemia, Chvostek and Trossy sign. Okay, now look at this. This is a very, very important thing which they ask in exam. It is Kaposi sarcoma. Kaposi sarcoma. So now this is a topic which they are trending in exam. They are asking again and again. So first of all, remember it's a vascular tumor. It is a vascular tumor. Then remember it is seen in HIV patient or immunocompromised patient, and it is due to HHV8. HHV8. अब आपसे क्वेश्चन पिछली बार पूछा था, लास्ट टाइम व्हाट दे हैव आस्क्ड यू लाइक HHV8 कैन इट कॉज सम अदर थिंग. HHV8 से कुछ और होता है. तो HHV8 कैन आल्सो कॉज प्राइमरी इफ्यूजन लिम्फोमा. प्राइमरी इफ्यूजन लिम्फोमा. Second thing, remember HHV8, it can also cause a condition called Castleman disease. It can cause Castleman disease. Castleman disease. So these are the things which they ask you in exam from Kaposi sarcoma. And remember this image based question, ये image भी 2-3 बार exam में आ चुकी है. This image came nearly 2 times in exam. Is it clear? Okay, now what it is? Anyone? तो ये भी photo बार बार आता है. This is which you can see this is like microscopy of India ink preparation. What we call this is Cryptococcus. So ये दो photo like they ask as a part of microbiology, or I can say infectious medicine. So Cryptococcus you can see which they ask in exam. Both the slides. Sometime कभी कभी this Saburot's agar wali image पूछते this one, and sometime what they ask you this image, Cryptococcus. Okay, now look at this. This is like a direct fluorescent test which we do for Legionella. So sometime they ask you this image. This is image for Legionella. Okay, then look at the skin. Try to understand this thing. They ask you question on different type of lung volume, and I can say which is obstructive disease, which is restrictive lung disease. So just remember एक diagram आता है flow chart based MCQ which they ask in exam. So you can see this is normal, and when we have restrictive defect, so they will deviate towards left side, and we have obstructive defect, you can see this type of pattern. So graph will be plotted toward this side. So when you compare this, look at this, what they ask you. In obstructive lung disease, you can see this type of graph. So sometimes they ask you this graph in like a flow volume loop. In restrictive, you can see this type of pattern. So generally, आपसे exam में दो ही पूछते हैं, obstructive and restrictive. Okay, now what else they ask you? Understand this thing. They ask you question on lung tumor. So we have benign lung tumor, we have malignant lung tumor. So in benign lung tumor, most common what we have hamartoma. In malignant lung tumor, we have different cancer like small cell, squamous cell, adenocarcinoma. Second benign tumor will be bronchoadenoma. Then sometime many cancers they go into the lungs, and when they go into the lungs, they will have cannonball appearance. On X-ray, you can see these white fluffy opacity. These white fluffy opacity is what we call this cannonball appearance. So ये भी photo एक बार exam में आया हुआ है. Okay, now in malignant tumor, what they ask you, we have small cell and we have non-small cell. So small cell is also called as oat cell. So here what you have to remember for exam, you have to remember certain A. Certain A means this tumor will produce ACTH. अगर ACTH ज़्यादा होगा, then patient can develop more cortisol. More cortisol means Cushing. Then this tumor will produce more ADH. If there is more ADH, then what we call this SIADH. Then there will be like antibodies which are against the calcium channel. There will be antibodies against PQ type of calcium channel. And these antibody against PQ type of calcium channel, what we call them? We call them Lambert-Eaton syndrome. So these are 3 paraneoplastic symptoms which you have to remember for small cell lung cancer. Okay, now coming to large cell lung cancer, it is considered diagnosis of exclusion. So here just remember one thing, only few patients will have gynecomastia. So only finding which we see here will be gynecomastia. Coming to squamous cell. Squamous cell, understand this thing, it is a cancer where patient will have more calcium. More calcium means it will cause hypercalcemia, and this hypercalcemia will occur because of a protein called PTHRP, parathyroid hormone related peptide. And now coming to most common carcinoma, in India it is squamous cell, in the western countries adenocarcinoma. ऐसा क्यों? Because हमारे यहाँ क्या होती है, हमारे यहाँ बीड़ी का बंडल होता है. So most common cancer in बीड़ी users, it is squamous cell. Adenocarcinoma, what they ask you, like it can present to you with like thrombophlebitis, there will be like varicose vein, DVT. So it is having thrombophlebitis. So this is about your lung cancer. Okay, now look at this. They ask you a question on OSA and OHS. अब इसको समझो एक बार. Obstructive sleep apnea and obesity hypoventilation syndrome, दोनों में differentiate कैसे करना होता है, ये क्वेश्चन बार बार आ रहा है. And most students, they go in the exam, they mark the answer OSA and come back कि हमने सही किया. देखो, patient here is mostly obese. Patient ज़्यादातर मोटा होगा. अब इसके नाम में obesity है, नाम में obesity है, तो here patient will be always obese. Patient हमेशा ही मोटा होगा. So whenever you see a patient who is mostly obese, or you can see patient is always obese, so understand this thing. In OHS, in obesity hypoventilation syndrome, you will see patient का PaCO2 बड़ा होगा. PaCO2 बड़ा होगा means this patient will be in a state of respiratory acidosis. So patient will always have respiratory acidosis. So that is the classical finding which we see in obesity hypoventilation syndrome. Now what they ask you, suppose you are having a patient who is having OSA or OHS. How we make a diagnosis? So investigation of choice, it will be sleep study. We call this polysomnography. Polysomnography. Now understand this thing. They ask you what is not a part of polysomnography. Remember, ABG is not a part. So polysomnography we use in RBD, means REM sleep behavioral disorder. You can use this in OSA. Even you can use this for OHS. You can use this for narcolepsy. Then central sleep apnea. जैसे member हो सकता है इस बार एग्जाम में इसको पूछ ले. It is also called as Ondine curse. Ondine curse, and it occurs because of FOX2B gene mutation. It occurs because of FOX2B gene. So these are the condition where you will do polysomnography. एक प्रोग्नोस्टिक स्केल होती है, बस आपको नाम याद रखना, उसको बोलते हैं Epworth Sleepiness Scale. So they ask you Epworth Sleepiness Scale. It is done for obstructive sleep apnea. Done? Okay, now understand. What they ask you in exam, they ask you like these are certain signs, like we call this halo sign, monod sign, halo sign, monod sign, and what we can see here, you can see this air crescent sign. Halo sign, monod sign, air crescent sign. So these are signs that we see in ABPA, means allergic bronchopulmonary aspergillosis, ABPA. Halo sign, monod sign, air crescent sign. Okay, now they ask you question on pleural effusion. So पहले इसको समझो. So how we make a diagnosis of fusion? For this what we need Lights criteria. We need Lights criteria to make a diagnosis. They ask you like where we get exudative, where we get transudative effusion. So understand this thing. Then certain drugs, These are drugs which can cause effusion. These are drugs causing pleural effusion. So especially जो एग्जाम में बार बार पूछते हैं, that is dantrolene. Remember, dantrolene is a drug that we use for malignant hyperthermia and that can cause pleural effusion. Now exudate, अब इसको देखो, exudate का मतलब क्या होता है? Anything which is thick. Thick means अब कोई चीज गाढ़ी कैसे होगी? सपोज ये पानी की बॉटल है, इसको गाढ़ा करना, तो गाढ़ा कैसे करोगे? इसमें प्रोटीन मिला दो. प्रोटीन, बॉडी में प्रोटीन कब होती है? इन ऑटोइम्यून डिसीज. So whenever you see autoimmune disease, you will find exudative effusion. और क्या मिला दो? Cells मिला दो. Add some cells. Where body will have cells? In infection. किसी infection में WBC बढ़ेंगे, means कभी lymphocyte, in virus like in bacteria we get neutrophils. In cancer also we have cells. Malignancy. So just remember, in cancer, infection, autoimmune disease, what you will get? You will get an exudate. Simple. तो देखो ध्यान से, neoplastic condition means cancers, infections, TB or any bacterial infection, autoimmune disease, or we call them collagen vascular disease. So here you will get an exudate. Now they ask you what we get. Investigation of choice for minimal effusion, it will be CT scan, and in this you will get the sign called split pleura sign. You can see this is called split pleura sign. And sometimes we can get Ellis curve. In X-ray you can see Ellis sigmoid shaped curve, we call this Ellis curve. Okay, now what else they ask you? They ask you question on pulmonary embolism. So in pulmonary embolism, what type of thing they ask you? So we have certain X-ray finding in pulmonary embolism. So what are these X-ray finding? What we get? So look at this first. What you can see these arrows are there pointing down. You can see this is what we call, we can see focal oligemia, we call this Westermarck sign. Westermarck sign. Then you can see a density here which is slightly above the diaphragm. This hump is there, a projection is there, so we call this Hampton hump. Hampton hump. And what it is, you can notice this is what we call this an enlarged vessels, we call this Palla sign. So these are the signs which we see in pulmonary embolism. Okay, this is bilateral whiteout, you can see bilateral whiteout you can see in a patient of ARDS. So you can see bilateral whiteout. Okay, ARDS they ask you, it can occur because of any direct or indirect cause, but most common cause of ARDS, it will be sepsis. If you ask me most common direct cause of ARDS, it will be pneumonia. और क्या पेपर में पूछते हैं? They ask you it can occur because of multiple transfusion, and then what we use, we call the name, इसको क्या बोलते हैं? TRALI. TRALI means transfusion associated acute lung injury. TRALI is nothing, it's a type of ARDS. Then sometimes they ask you it can occur after pancreatitis. So these are 4 things which they ask in exam. So in ARDS, understand this thing, how we make a diagnosis. So ARDS means 7 दिन पहले patient बिल्कुल ठीक था. So onset will be less than 7 days. So onset will be less than 7 days. Then you can see in X-ray it will be bilateral whiteout. Bilateral whiteout means you can see bilateral infiltrate. So we can say bilateral whiteout in X-ray or bilateral infiltrate. अब देखो ARDS having nothing to do with the heart. ARDS में heart का कुछ लेना देना नहीं है. Heart is perfectly normal. Heart is perfectly normal means you can see left atrial pressure, or I can say pulmonary capillary wedge pressure. This will be normal. ये कैसा होगा? Normal. So left atrial pressure or pulmonary capillary wedge pressure will be normal. ये normal होना चाहिए. Heart has nothing to do. And we see PaO2 is to FiO2 ratio. It will be less than 300. इसके साथ what you need, we need triggers. And what are the triggers? Trigger क्या होगा? Trigger could be infection. What will be the trigger? Triggers will be certain infection, or it could be pneumonia, it could be sepsis. So this is what मैंने आज आपके सामने लिखा है. इसको बोलते हैं Berlin's criteria. And they ask you Berlin's criteria. It is used to diagnose ARDS. Very, very important. Berlin's criteria is used to diagnose ARDS. So this is about your ARDS. Done. Okay, now try to understand. They ask you question like this. Image also came in exam. It is silicosis image. You can see like crazy pavement pattern. ये CT का image बार-बार exam में आता है. That we see in a patient of silicosis. This is, you can see, shaggy heart border, and this is like you can see like leaf-like pattern, holy leaf sign. तो उसको बोलते हैं shaggy heart border. Shaggy heart border, holy leaf sign. So these are finding which we see in asbestosis. These are finding which we see in asbestosis. Done. Okay, lung abscess. They ask you most common causes aspiration. Most common lobe in primary will be posterior upper lobe and superior lower lobe, and lung cancer is unlikely in lung abscess. Even sometimes they ask you in lung abscess, primary lung abscess, most common cause will be anaerobes. In secondary, it could be due to staphylococcus aureus, or sometimes it could be due to mixed bag of infection. Okay, now try to understand. They ask you question, lung cancer is not seen in bronchiectasis. So bronchiectasis का एक case बार-बार exam में आता है, and or they ask you like this investigation of choice. This CT scan also they ask in exam. It is HRCT. So patient will have bronchoria. Okay, now understand this thing. They ask you like blue bloater, pink puffers. Blue bloater means bronchitis, pink puffers means emphysema. So bronchitis, it is considered dangerous because patient will have risk of right heart failure. We call this cor pulmonale. And pink puffers means patient will have risk of emphysema. Risk of emphysema. These are 3 C's. We call them 3 C's means Cushman spirals, Charcot-Eden crystals, Cruella bodies. We call them 3 C's of asthma. 3 C's of asthma. Okay, the next thing which is trending is Legionella से question बार-बार exam में आ रहा है. तो देखो, Legionella will cause both typical and atypical pneumonia. It can cause both typical and atypical pneumonia. Home split AC will not cause Legionella pneumonia. Legionella में क्या होगा, पेशेंट को निमोनिया के साथ डायरिया होता है, वेरी वेरी इंपॉर्टेंट. तो बिकॉज ऑफ डायरिया ही विल हैव हाइपोनेट्रीमिया. Even this came as a question. Then we have urine antigen detection test, and they ask you like, so these are all the MCQs which they ask on Legionella. Nematocele के साथ अगर निमोनिया होगा, nematocele के साथ, so it is generally caused by Staphylococcus aureus. And non-specific marker of pneumonia, it's also non-specific marker of sepsis, that is your procalcitonin. Procalcitonin. Clear? Okay, then this photo also they ask in exam. We call this Bell's palsy photo. कभी-कभी पेपर में आती है. Then look at this. They ask you upper and lower motor neuron disease, upper motor and as well as lower motor involvement. We call this ALS. Amyotrophic lateral sclerosis. We also call this Lou Gehrig's disease. Lou Gehrig was American baseball player. उनको disease थी. Lou Gehrig disease. Then they ask you question on location of stroke and their blood supply. So midbrain will have P1 PCA, Pontine will have basilar artery, middle medullary will have anterspinal artery, lateral will have vertebral artery. तो कभी-कभी stroke से सीधे क्वेश्चन पूछने एग्जाम में. Now what else is important? Now understand this thing. They ask you, ये भी इमेज एग्जाम में आई थी आपके एग्जाम में. It is your neurocystic sarcosis, NCC. Neurocystic sarcosis. Also just remember, like initially what we have to use, how we manage initially this thing. Never give albendazole or antipyretic drug immediately. आपको सीधे antipyretic drug नहीं देने हैं. सबसे पहले आप क्या करोगे? We have to use steroid. We can use steroid. We can give certain drugs which can decrease cerebral edema. So we can use mannitol. We can use drugs to decrease edema. Then we can use anti-epileptic drugs. Even steroid also decrease edema. So we have to first give symptomatic management. Once patient is settled, then we will use anti-parasite drug. Simple. NCC. Okay, now they ask you like, this is image-based question. This is your severe type of hemorrhagic infarct, and this you can see when you see a dark, we call this ischemic infarct. Then look at again these images. This is like a severe form of SH. You can see bleeding near Sylvian fissure. We call this subarachnoid hemorrhage. So these are different type of, you can see this is your CT scan which they ask in exam based on hemorrhage. Again you can see this is hemorrhagic infarct. Okay, now look at this eye of tiger appearance. It is seen in Haller-Walden's Part syndrome. You can say this is your, I can say hummingbird sign. Hummingbird sign कहाँ मिलेगा? It is seen in PSP, progressive supranuclear palsy, and it's called hot cross bun appearance. It is seen in MSA, multisystem atrophy, and this is your panda sign, and panda sign where we see in Wilson disease. So ये कहाँ पर होगा? Hallo-Warden-Spart syndrome. Hallo-Warden-Spart syndrome. Done. Okay, now understand. What else they ask you? Myasthenia के साथ अगर MRS है, then we have to use daptomycin. Myasthenia will have resistant to succinyl choline. So myasthenia के diagnosis से question कई बार एग्जाम में पूछते हैं. So what they ask you in diagnosis part to understand this thing. So myasthenia के लिए what we can do a test called ISPAC test. We can do a test called ISPAC test. Then for myasthenia, what else we can do? We can do for screening tensilon test. Tensilon test. For myasthenia, what else we can do? और क्या आप कर सकते हो? In myasthenia gravis, single fiber electromyography. Here you will find jitteriness. Then you can do repetitive nerve stimulation. In this you will find decremental response. But अगर मैं आपसे बोलूँ best test will be we need to find antibodies. We have to detect antibody. So antibody detection will be the best test. And this antibody, how we can detect? Which antibody we have? We have anti-acetylcholine receptor antibody. Second antibody which they ask in exam is anti-MuSK antibody, anti-muscle specific kinase, and third will be your anti-LRP4. So these are the antibody which we can find. Done. So this is, you can see like myasthenia will have this snarling face, vertical opening of mouth. You can see this is tensilon test, means after giving adrophonium, you can see first patient having ptosis, then ptosis will improve. This is ISPAC test. So after you can see ptosis, you can see after ice, ptosis is improved. We call this ISPAC test. Again you can see vertical opening of mouth, we call snarling face. Okay, now try to understand. There are certain topics which I am describing here which are important and which they ask again and again in exam, बार बार exam में पूछते हैं. So those topics, let us understand this thing. So I will add those things. So first you can see this is summary of all the different types of leukemia. AML, CML, CLL, Hodgkin lymphoma, non-Hodgkin lymphoma. So this thing is something which I am adding in this PDF. So it is a summary of all the leukemia lymphoma. Just you can go through this once, you will get an idea. Next, what they ask you question on, sometime what they ask you a question on a genetic table and hypersensitivity reaction. Genetic table and hypersensitivity reaction means like they ask you which type of hypersensitivity is myasthenia gravis, or they ask you which type of hypersensitivity you will see in a patient of like blood transfusion reaction. So ऐसा question exam में आता है. So just I am summarizing all the important thing which they ask in exam, and that is important for your exam because just उसको एक बार exam से पहले आपको एक बार पलट के देखना है. That's it. That is what you have to do. So this is about your genetic table. They ask you कौन सा autosomal dominant है, कौन सा autosomal recessive है. So this type of table they ask again and again in exam. It's very, very important. Okay guys, can you see the screen? Screen दिख रही है? Okay guys, can you see the screen? Screen दिख रही है? Screen नहीं आ रही है. Screen नहीं आ रही. स्क्रीन नहीं आ रही है. स्क्रीन नहीं आ रही. Okay, so I have summarized these three tables in front of you. First is the table of leukemia, which you can see. So PYQs means which came in exam. So सारे question भी इसमें add है. Then second is a table of autosomal dominant, autosomal recessive. यहाँ से तीन तरीके का question आता है. एक all accept fashion. एक आपसे पूछते हैं like clinical case they'll ask you what is the type of inheritance. Or sometime what they ask you simple one liner like familial adenomatous polyposis having which type of inheritance. Third thing is what they ask you question on different types of anemia. तो ये तीनों चीज़ें मैंने यहाँ पर समराइज कर दी है. तो बस ज़्यादा आप सोचना नहीं है. जैसे मेंबर विद दिस आई विल कंक्लूड द सेशन. अब सबने अच्छा पढ़ लिया है, सब अच्छा होगा. जस्ट गो इन एग्जाम विद अ पॉजिटिव एटीट्यूड एंड रिमेंबर यू कैन, यू विल स्टील द शो. तो पॉजिटिव रहो, कॉन्फिडेंट रहो. तो एग्जाम के बाद मिलते हैं विद अ स्माइल ऑन योर फेस. ऑल द बेस्ट. बाय बाय.
हाँ अभी अल्ट्रा व्यूअर है, कनेक्ट है अभी.